So, 12:30, we're going to start. I can see we've still got some people not quite made it with us yet, but we're going to start anyway. We've got a busy agenda, long afternoon, and I'm sure you all want to put me under pressure to finish on time. So that is my objective, or one of them. Welcome to everybody. Now, I was going to say welcome to Frankie, and to note that it was Frankie's last meeting, but I don't think we've got Frankie. Frankie's got traffic problems. So we'll record in the minutes that we said as a board thank you to Frankie for everything she's done for Norfolk and Waveney ICB, and indeed SNE, and Norfolk and Suffolk. But we'll also note that Ed will be giving a proper and more fulsome thank you in his introduction. I also want to say thanks to all our retired and indeed retiring members, and indeed here is Frankie. So welcome, Frankie. I think you're here. So, but retired and retiring members, thank you to everybody, of course. This is our first in-public meeting as Norfolk and Suffolk ICB. We have met, of course, virtually before, but I think we ought to record in a public session thank you to all our Norfolk and Waveney ICB members and Suffolk and North East Essex ICB members who are no longer with us. Thanks for everything they've done. And in particular, in fact, over the past week, 10 days or so, we've lost Councillor Steve Wiles and Councillor Fran Wymark as a result of the local elections, and yet to find out who will be replacing them, which we should know by the end of the month, hopefully. But thank you to Steve Wiles and Fran Wymark for their contributions. Now, I'm not going to do introductions to guests who are here with us today. There are a lot of guests who are helping with the papers and presentations, so I'll leave it to the lead exec director to introduce the guests that we have at the appropriate time. Apologies, and Tom, you'll check that I've got this list right. I have on my list Maddie Baker-Woods, Matthew Wynne, Dave Cargill, and Caroline Donovan, but we have Faisal here for Caroline. Thank you, Faisal. And Adele Maiden will be a little late. She's got another commitment, so she'll be with us around about 2 o'clock. Have I missed any, Tom? All done? Good, good. In which case, let's then go on to item 2, which is a notification of questions from the public. Now, we have a very long list today. Actually, there are 10 questions in the list. What I'm going to do is take those under agenda item 19, which is towards the end of the standard agenda. The exec director responsible will read out an appropriate précis of the question and the answer, but the full question and the full answer will go on the website in the normal course. So please be assured, those members of the public who have raised questions, your full question and your full answer will go on the website. One thing to perhaps note from a board perspective is that in theory, whilst we want to be as open as possible, open and transparent as possible, in theory, questions that we accept for the ICB board meetings should be pertinent to a specific agenda item. Now, to be fair, we've been quite flexible over that over the past number of years and accepted most, if not all, questions, whether agenda directed or not. If, however, we continue to get a large number of questions which take a significant amount of time from the board point of view in public session, over and above that which is normally allowed in the agenda, we're going to have to be more strict over the interpretation of which questions are acceptable. Therefore, could I encourage members of the public who want to raise questions to, in future, to be very specific about which agenda item they are referring to, and also particularly what the actual question is. So be very specific about the question and which agenda item it pertains to. So thank you in anticipation for that. Item 3. Declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item other than those of which we are aware and which are on the register? No hands raised, no declaration. Minutes of the previous meetings, item 4. First of all, the 25th of March, which was in fact the last in common meeting of Norfolk and Waveney ICB and Suffolk and North East Essex ICB, 25th of March, the last in common meeting. For accuracy first, please. Any issues over accuracy? Elaine, did you want to comment? Yeah.
It was just really a comment, because I did note there was a number of actions we agreed in the meeting that are captured in the action log. For consistency, I think it would just be helpful to also have them marked explicitly in the minutes so that it's clear the context for the actions that were being tracked.
So would you be happy, Elaine, if we asked Tom to take an action to make sure that those are that are in the action log, assuming when we get there we approve them, feature clearly in the standard way in the minutes?
Yes, I think that'd be helpful, thank you.
With that amendment for the 25th of March in common meeting, are we happy to approve as a true and accurate record? Resolved, agreed, thank you very much. And then the 1st of April, which was the first Norfolk and Suffolk ICB meeting, I'll do accuracy first, I think, as was at the time, but then we ought to reflect on the memberships that are listed on actually it's page 19 of the pack that you have in front of you. But let's do accuracy first as of the 1st of April. Any points around accuracy? Otherwise resolved to accept as a true and accurate record? Agreed. Now, the 2 points that I would raise, I think, first of all, are on section 3.3, subsection 5, as far as I recall, on page 19, where we actually record the membership or the co-chairs of the Integrated Care Partnership as myself, Councillor Steve Wiles and Councillor Fran Wymark. So we should note then today that as we've already discussed, Councillor Wymark and Wiles are no longer with us, so that will require an action going forward to complete the new ICP chairs group. And then there was an action at 3.3 subsection 6 also for me around the Norfolk and Suffolk committees, which where it was identified that the chair, i.e. me, would appoint a chair of those committees. I'm very happy to confirm that I've asked Elaine to do this, and Elaine, unless you tell me differently now, you've accepted. Thank you very much. That then takes us on to the action logs as presented. But as far as I can tell, with the exception of one item for Mark, which I'll come to, all are either complete or on the agenda or not due. So let's see if people agree with that in a minute, Mark, but if I could come to you for an update on the Benjamin Court matter arising.
Thank you, Chair. Yes, so I'm pleased to report that since the last meeting when the campaign group joined us for the day, or for the afternoon, we have met with them. Myself and Simon met with the campaigners on the 12th of May, had a very constructive discussion around, more broadly around the needs of the population in and around the Cromer and North Norfolk area, and we have agreed to meet again in the next couple of months to work through some options. So it was a constructive meeting. We were grateful to them for the way they they interacted with us, and we're keen to hear their views and work together going forward. So we'll bring further updates in due course, if that's okay.
Thank you, Mark. Any questions for Mark on that update? Okay, and then for the Matters Arising action log as presented, with Mark's update and then the 2 actions that I mentioned from the 1st of April meeting vis-à-vis Elaine, Councillor Wymark and Councillor Wiles. Is everybody content that the action log, that you are content with the action log as presented? And nods all around the table. And are you content that it accurately captures the actions you think it should have done? Agreed. True and accurate record in every respect. Great. Thank you very much, everybody. In which case, item 6, the CEO's report. Ed, over to you.
Thank you, Will, and well done, everyone, for finding the room. I took a little bit of time, but I eventually got here. So, firstly, I thank you. We've launched a new organisation since we last met. Thank you to everyone's professionalism to get the organisation launched, and for all the support you've given the staff in various ways over the last few months, and continue to do so, of course. We've got 3 values. I'm just looking at the values at the back. I think they're quite similar to the NSFT values, but the first value is around kindness. There's a very good phrase about the care you walk past is the care you accept in healthcare. And so being kind isn't walking past poor care, it's actually doing something about it. So that's a crucial value for us. Secondly, around collaboration. And I think there's a very nice atmosphere and spirit in this board, but I think we all recognise if we want to give children the best start in life, or if we want people to feel well, we've got to collaborate. You know, to improve an outcome, you've got to work as a team across all partners, so that's very important to us. And thirdly, ambition, and I think the NSFT value is better, but we want better, don't we? We want to be really ambitious and to deliver the best possible outcomes for the people of Norfolk and Suffolk. So I think if we can deliver on those 3 values, we'll do a half-decent job. So firstly, a big congratulations to Frankie. As we know, she's been appointed as National Medical Director for NHS England and Department of Health and Social Care, which is an extraordinary achievement, and we're all exceptionally proud of her and of the achievement. I know Frankie has said to me that when you're a clinician, you're supporting the patient in front of you, but the attraction to an ICB role is that you're supporting 1.7 million patients in front of you and thinking strategically how you can do it. She's about to be supporting 58 million, 0.6 patients across England, so we know she likes healthcare at scale. A couple of examples of Frankie's leadership for the board that have just come through is Norfolk and Waveney ICB, as it was, has delivered the biggest increase in the early diagnosis of cancer of over 4% in the last year, which is incredibly impressive, and that hasn't happened by accident. It's all the concentrated leadership that Frankie and others have shown have delivered that outcome. Secondly, the ICB has delivered the highest referrals to the digital weight management services in the country, delivering 187% of target. So it just shows you, with great clinical leadership, proactive behaviour, use of PHM, working with our neighbourhoods, our communities, we can deliver improved outcomes. So thank you, Frankie, for all you do and the impact that you make in our communities, and we'll continue to make, I'm sure. Thank you also to Mike and David in the audience. So they're Frankie's deputies. They're going to be acting up together in the interim whilst we go out to recruit. I think the interview date is planned for later in June, so possibly by the next board we'll have made an appointment. But thank you so much, both of you, for stepping up and supporting us and for all your leadership. Equally, on the national stage, I just wanted to recognise Richard's contribution. So Richard's the National Director for Strategic Commissioning. He's delivered a strategic commissioning framework for the NHS and recently secured, I think it was 11 million pounds worth of funding for a development programme for ICBs up and down the country. So, it shows, I think, that we're contributing locally but also nationally. So thank you, Richard, for all that you're doing. Since we last met, we've launched our Strategic Commissioning Committee, which is like the engine room, I think, of our transformation work. We have approved the Care Management Service commissioning for Suffolk. There are a number of big transformation programs coming through too, and I think it's really exciting, actually. We've got resource to spend, and we've got some great plans. So I think this board needs to pay close attention to that committee and its work and all of the transformation that's coming through. Equally, I think there's been a lot of great work on neighbourhoods and accelerating that. We had a great session in Norfolk recently, and thank you, Ian, for your support with that. And equally in Suffolk too, as a major event today. So there's a lot of energy and progress, I think, now being gathered around neighbourhoods. I wanted to congratulate Norfolk County Council, their children's services have been given outstanding across the board for every category, which is not a surprise to us, but an enormous achievement. And I'm very interested to actually speak to Sarah about what it is, what have they done to be quite so outstanding. I know they're in the top 2% of local authorities for children's services in the country, so we can learn a lot from them. Equally, Norfolk and Suffolk Foundation Trusts have just been given a good for their older adults inpatient services. Another really strong sign in terms of progress being made. And the Ambulance Trust have delivered the best performance in 5 years in terms of their Category 1 and Category 2 response times. So some really good progress there from a number of our local providers. There's been a national nursing apprenticeship scheme launched, and we will receive our share of 2,000 new nursing degree apprenticeships locally, which I know Lisa and Amanda and others are very excited about. We've launched a Norfolk and Suffolk Women's Health app, so do download it if you want advice on various related health issues, and we're really proud of that. I think it's a national first. A lot of work underway around the new hospital programme, working closely particularly with Leslie and Ewan. The team had a visit to the West Suffolk site recently, and thank you for that, Ewan. And particularly with that site, we're looking for spades in the ground for 2028, I think is the intention. So it's really not that far away now, which is really, really exciting. What else can I say? New dental school at the University of East Anglia. So that's been a hard-fought campaign. There's huge merit, obviously, in that, given that East of England is traditionally seen as rather a dental desert, and we haven't got a university provider providing undergraduate placements, a scheme and placements. So we're absolutely delighted that they've achieved that, and that will be a big part of our wider oral health strategy going forward. And then finally, we have organised a Norfolk and Suffolk Expo for the 3rd of July at Newmarket Racecourse, where we will be showcasing innovation from across the two counties, across all of our sectors and partners. And there's a Health and Care Awards ceremony as well. I know there's been a big interest and a number of nominations for people. So we're excited to attend that event. Thank you, Chair.
Ed, thank you very much. Lots of good news there, but open to questions from colleagues or Ed on any of those matters, or indeed anything else. No? All good? In which case, Ed, thank you very much. Received and noted. Everybody happy? Wonderful. In which case, let's move on to item 7, the shift to neighbourhood working across Norfolk and Suffolk. Now, Mark, I'm going to go over to you to organise this and introduce your speakers, and all in your hands.
Thank you very much, Chair. And first I should say thank you very much for allowing us such a considerable part of the agenda to discuss what is a really important topic for us, I think, as an ICB and as a system. I'll just say a few brief words, and Ian will also, but I'm incredibly grateful and very pleased to introduce Kat Proctor from the Care Company, who's going to bring the item alive for us today and share share Catherine's story, which is incredibly powerful, I'm sure you'll agree, but I think absolutely makes the case for the work that we're planning and wish to do together across Norfolk and Waveney. And also to introduce Emma Bugg, our Associate Director of Place and Neighbourhood for the Central Norfolk System, who there's some detail in the papers included about some really good work that is happening in central Norwich, to bring that alive again there as well. But before we hand over, I think it's important to stress my colleague Maddie Baker-Woods updated on the Suffolk position at the last meeting, and aligned to that, our plan today is to just share a bit more about the Norfolk and Way option, which is absolutely aligned. Ian and Ian's team and I and my team have planned this together. I think that's a really important thing to do. We've been working closely with local authority partners and many others on this agenda. I know we've discussed here before, in terms of the health and well-being of our population, actually our role as health is a relatively small part of that. You know, it's so important that we link in with housing, a person's income, environment, relationships play such an important part of the health and well-being, so that's why we must do it that way. For me, neighbourhood health is fundamentally about people. People and our communities. It's about listening and about better joining up the care that we provide, and making sure we do that better going forward. So I think our plans that are shaping up, that we've shared detail of in the paper, hopefully give you some good insight into what we hope to do. But I think Kat's going to make the case of why this is absolutely necessary for us to do this. Yes, it's great that it's a national direction and that the current evidence and the thinking suggests neighbourhood approach is the right one, but I passionately believe I should do with my title and my role, shouldn't I, that neighbourhood is the way that we will deliver far better outcomes for the people and residents of Norfolk and Waveney. So I think we can make a real difference here. As I say, I'm very grateful, but Ian, would you like to say a few words before we hand over? Thanks.
Thank you. I apologise to colleagues who were in the workshop 2 weeks ago, because you probably, what I'm going to say will sound a little familiar, but I am going to say it again because I think it's important. So my overarching observation is that public services at best are, I think, pretty challenged at the moment. People would recognise, some would say fundamentally broken. Demand is rising at a rate that outstrips our ability to pay for it, and despite the fact we are pumping in more and more resources, outcomes are not improving at a fast enough rate. And I think the public recognises this. And so my premise this afternoon is that it's not enough to do the same things a bit differently. We've got to do fundamentally different things. And this is what, for me, this neighbourhood programme is all about. We need to be really bold and we need to be really ambitious. And so what are those what are those different things that I've come up with 4 suggestions. The first, and perhaps the most important, is we need a shift in the system from one that's transactional and process-driven to one that's relational, that values human relationships. I believe we're having the wrong conversation as public sector organisations. The conversation we've been having, perhaps for the last 30, 35 years, is how much of what we've predetermined we do in advance are you eligible for? We see the world through our services, and that creates a pixelated view of residents. We see them as a cardiovascular disease problem, or a respiratory problem, or a homelessness problem, or a mental health problem, or an obesity problem, or a care problem, rather than a complete human being that's unique with their own dreams and their own goals. And when you do that, when you start to see the world through services rather than through people, then you get more services. When you start with people and relationships, you get genuine solutions. And so we've got to shift the conversation. We've got to shift it from that eligibility conversation to a what matters to you conversation. What really matters to you, and how can we help you achieve your goals as you define them? And so we need to shift as a result from a one-size-fits-all solution. Kat's going to talk, I think, about boxes and trying to fit residents into our neat boxes, into something that's genuinely bespoke, that's genuinely unique to each resident. In doing so, we need to work relationally as professionals. So we need to stop even in MDT saying, no, it's not me, it's you, no, it's not me, it's you, no, it's not me, it's you. And actually say, collectively, what's really important to you, the resident, and how can we have little bits of each of us around a unique and bespoke solution. The second is to shift, and I've just really alluded to it there, from fragmented to integrated. We've set the system up to deal with single issues, and yet residents don't live their lives like that. We know there's a huge overlap between mental and physical health problems, care needs, housing needs, addiction needs, death. And yet these things are delivered by different teams in different organisations at different times in different places. And so I coined the phrase the needs paradox. The greater someone's need, the more overlapping problems they have, the harder we make it for that resident to access help, because the more front doors they have to go through. And so we need a neighbourhood approach that brings together professionals from a variety of different teams and different organisations co-located at neighbourhood level to work together to plan care around a resident. The third shift is from deficits to assets based. There is a wealth of operating capacity that we can play into that unique bespoke solution that exists within the community. We know that loneliness has a huge impact on health, the positive impact that social relationships can play, the huge impact that exercise or music or gardening can have on mental health. And we're really blessed in Norfolk, and Tim can attest to this, a hugely strong community and voluntary sector. And yet, as public sector organisations, we've historically been really rubbish at playing that into that bespoke solution. And as a result, we limit our own operating capacity. And then finally, from reactive treatment to proactive prevention. A huge proportion of our collective budgets are spent on a relatively small number of people. I think about 60% of our budgets are spent on those with frailty, end-of-life dementia, or complexity that overlapping problems of physical and mental health needs and care needs and housing and addiction. And below that, there'll be a cohort with multi-morbidity that is at risk of becoming into the 60%. And so we have to really focus to become far more proactive at preventing disease and ill health rather than waiting until it hits our front door. So those for me are the four magic ingredients of a neighbourhood approach. I wanted you, well, in a bit we're going to hear from Emma, because I think Emma has devised a solution to this despite the system. So Emma's the solution. But first I wanted to hear from you, hear Kat speak. As Mark says, one of our home care providers. And Kat's going to tell a resident story, that of a woman called Catherine, whom she cared for. I've heard it several times before. In fact, I think it's so powerful, I asked Kat to tell it to all of my managers as part of our new operating work. It's powerful and it's uncomfortable because it's a story about failure. And what really strikes me about this story is that none of the professionals within it did anything wrong. They didn't do anything that we hadn't asked them to do. That everyone did exactly what we'd asked them to do. And it demonstrates, therefore, that actually it's the system that we've built collectively that is failing our residents. And I think it provides us as system leaders with a moral imperative to change that system. And so I'll hand over to Kat. Thank you.
So this is Catherine. Before I tell you her story, it's important to tell you who she is and who she was. She was a mother. She was a businesswoman, she was funny, she was strong, she was independent, and she was someone that became really inspirational to me and someone that made me want to fight back and say, this isn't okay. So this is Catherine's timeline. I knew Catherine for only a few months, and there were so many occasions that things did not work and we didn't work together or we couldn't access what Catherine needed. In May 2015, she was diagnosed with a brain tumour. She had treatment, continued to live independently, nursed her mum. And then in May 2025, the tumour returned. She went into hospital, she received treatment and was discharged with no care in place. She was given a reducing dose of steroids, but she had very little eyesight. She didn't understand what she needed to take and when, so when her son arrived a week later, she'd taken no medication. He contacted us, we started to provide the care. Very quickly, things changed for Catherine. We were having to be reactive because the deterioration happened so quickly. She eventually lost all sight, all hearing. We initially were just going in to administer her medication. And that is why she didn't receive a care package, because on discharge from hospital, she wasn't eligible for care because medication was not a need in itself to provide a care package. On the 13th of June, she attempted to go to the hairdressers. As I said, she was strong and independent, and she thought she could do it. She had a fall, and a member of the public took her home. We had joint visits with the matron. We contacted the GP because we were not clear on where to go with her medication, but the communication between the hospital to the GP and to the nursing teams, nobody could give us a clear answer. She needed a new hearing aid. The wait was too long, so her son had to pay for somebody to privately come and arrange a new hearing aid. We had no pain relief, even though she had this tumour, significant swelling, and when pain was increasing, we had to arrange for the GP to come and visit. But before that could happen, we had to get the community nurses to come and give anticipatory meds that had been sent without any basic pain relief being offered first. Very quickly, we were increasing the care visits. She was deteriorating with her swallow, so we asked for a referral to the SALT team. Again, it's all delayed, and we were not getting advice on what she could and couldn't have in the meantime. Time and time again, we had different nursing teams coming in. We had the palliative nurses, the community nurses, the urgent response nurses. None of them knew Catherine, none of them knew the history, and time again, we had to repeat everything that she'd been through. We get to the 17th of July, and the neighbours called 999 because she was shouting. The fire service broke the door down, even though the care staff were there and were going to use the key safe. They'd already put the foot through the door, which caused Catherine so much distress. They then left me for 6 hours to wait for Freebridge to come and repair the door, because they will enter, but they won't make it safe. And Catherine couldn't be left because she was in a flat with communal access. Her world started shrinking towards the end of July, and she could barely see, and she could hear very little without her hearing aid. The only thing she relied on was knowing who was there by the feel of their hand. We asked for a fast-track assessment, and she was not eligible for fast-track. They then said they would complete a CHC checklist, and every different team of nurses that attended said they couldn't complete it because they didn't know her well enough, and it had to be a different team. The CHC checklist never got completed. We had to arrange key safes, we had Enable, we had Careline installed. Careline rang my personal phone, and we responded time and time again. We then had urgent care therapy team involved. They did supply commodes on the same day. It was the quickest response we had from anybody. They wanted rails around the property. They asked Care and Repair to fit those, but Care and Repair refused because it was a Freebridge property, so they have to do their own. A 12-week wait. Assistive technology arrived. They came to do an assessment, but she wasn't eligible for visual support because she wasn't registered blind. Although she had no sight, she wasn't eligible for them to come and do an assessment. And when asked, how do I get a certificate of visual impairment, they said, we have to refer to the hospital. She also never saw those. We then had further police visits, each time Catherine getting more and more distressed. Fire service again broke the door, even though the They had the key safe number at this point. We'd given it to Careline. Careline passed it to, I've heard the call. They gave the key safe number, but the fire still broke the door down. The fire service then were very upset with me because the only way Catherine could find what she wanted was by feel. So she had everything at hand, which meant there was clutter. And the fire service said it was too great a risk. And I told them it was her home, it was her choice, and if you took that away, you took away her independence to find what she needed. Eventually, in September, Freebridge did come to fit the handrails. By then, Catherine was no longer very mobile and was too frightened to move around the house without anybody there. By the beginning of September, things really did start to change. Things really started to change for Catherine. Her swallow was nearly non-existent. She was choking. We had more GP nurses, each giving us different advice, different support, continual conflicting and not lined up services. On the 9th of September, fire door specialists came to repair the door properly because it had been broken twice and temporarily fixed. Another wait. We then had the steroids reduced because it was causing her hunger, but the choking risk had increased. So they withdrew the steroids to try and support that. We then had visit from the palliative nurses. Again, the CHC checklist was passed back to the community nurses. We then had medication and drug chart collected as prescribed by the palliative nurses, and when we needed to have those drugs administered by a nurse, they were not happy with how the drug chart was written, so they sent us back to the GP to collect a new drug chart whilst Catherine was screaming in pain because they wouldn't administer. We then had a community nurse visit. Her legs were dressed as they were swollen. They left dressings. A few days later, we needed the nurses to come back again for a different area, but we asked them to redress the legs. We were told, we can't do that, it's not on our job sheet today. Even though the dressings were there, they were visibly needed changing, we were told no. The 29th of September, Catherine was really struggling to swallow. Her speech changed. She went downhill very, very quickly. We called 111 for advice. We called the nursing teams. Catherine didn't want to go to hospital. We couldn't get acute help in that moment, so we said we would stay with her overnight. I called her son and I told him that things had changed very quickly and that he needed to come from London to be with her. The next day, her face and her tongue had started to really swell. She couldn't breathe very well. The nurses came to put the syringe driver in, but again, the chart was wrong. So we were consoling Catherine whilst the nurses was trying to speak to the doctor who said they were prescribed by the palliative nurse, so we had to go around the houses to just get medications that were there and ready to give. So whilst this happened, a hospital bed was delivered, but there was no plan of how to get her into that bed. There were no sheets for the bed. Eventually, we managed to get the urgent community team to come and help us to get her into the bed. The syringe driver went in, and we sat with Catherine. And later that day, she passed away, with us holding her hand, while she never reached the top of any list. Here is the number of services that were involved with Catherine in just a few short months, none of which communicated with each other. They worked acutely, doing their role, but time and time again, Catherine was misunderstood. We were told she wasn't safe. We were told she had to move her clothes. We were told she needed to go to Tapping House. She didn't want that. She wanted to stay at home. So These are just a few ways in which I think the system failed Catherine. And that was that she was not eligible for care needs at the beginning. She was not safe to go home alone. She needed support. And whether she met a checklist or not, she shouldn't have had to have her son pay for her care because she did not meet the criteria. She was not eligible for fast track. No one could complete a CHC checklist. The wait lists for SALT, for visual support, for sensory support, it was all too long. Incontinence service, again, they had to buy pads, 13-week wait for incontinence support. Hearing aid, without the hearing aid that they bought, she wouldn't have heard anything. Miscommunication between services, being told one thing by one and different by another, and continually passed from one team to another to take responsibility. All Catherine wanted was to spend time with her son, to have independence, to be treated with kindness, to have a choice, to be listened to, and to feel safe. She wanted someone to sit there and tell her what the news was of the day. She wanted to eat pan of raisin and have a Starbucks coffee. She didn't care what checklist she fitted. We saw Catherine and we listened and we advocated for her. We became the centre of her world and had to communicate between all these different services. Without that, she couldn't have done it by herself. Sometimes they came to us first, but other times they tried to visit without. But we became her eyes and her ears. She knew us, me and her main carer, from our hand. And when she was in moments of distress with an ambulance or the fire service, we would walk in, take her hand, and she would calm. We did what she needed when she needed it, whether it was our role or not. All that really mattered was that she had what she needed, that she could see her son every week, that she wasn't in pain, and that her wishes were listened to. Her son, Kenny, these are his words, I won't read them all to you, but he found it so distressing knowing where to go and where to get help. He was not able to access support for his mum, and it was only through him contacting us that he had a care provision in place. For me, Catherine was one of the most incredible people I've met. We shared a spirit, and she was let down by a system that she did not fit in and wouldn't have wanted to fit in any system. But it shouldn't have been that way. We should have fitted Catherine, and we should have looked at what she wanted. She often told me to tell my stories and put them in a book, but that will never happen. So, as it says up there, I'm privileged to have been part of her story, and so in her honour, I share hers. And I would love to say that Catherine's story is really unique, but it really isn't. Time and time again, even today, on the way here, I was in an MDT about a lady who has such complex needs, and every team within the MDT told me she is not eligible. She slides through the gaps in everybody's checklists. And in the meantime, she is making 40 to 50 phone calls every day to the ambulance service, to the nurses, to Swift, to social services, to us. She is having thousands of pounds in unplanned care because we cannot meet her needs. And as a care provider, we are not heard. We are not listened to, and sometimes our opinions are not valued because we are not the professionals within the room. But what we have is experience of knowing the person. And when I've asked for this, in this MDT today, for support with rehab and therapy to support her mental health, they say, we don't think it will work. Do you really believe that will work, Kat? And I say, I've seen it, we've turned her round, but I'm not listened to. I was asked to leave an MDT while the professionals had a conversation before I was allowed in about a lady that I knew for 4 years and everyone had met acutely. Time and time again, we are seeing deterioration in people that leads to increased care needs because we're not working together or being able to access services quickly enough to support them. The hospital will discharge because they want their bed. They don't look at what the environment is like in the community, whether they've got the equipment they need, whether they've got the care in place they need. They'll say there's no changes, but there are. And then we have to rely on the community teams that will take weeks. It happens every single week for us. And we see it over and over again. And it's really, really sad. That's it.
Thank you, Kat. I know that's really difficult for us all to hear, but I think it's really important that we do hear it. And your challenge to us that it's not heard, I think you'll see that from the silence in the room, it was absolutely heard today. I think one thing that's really important for us to acknowledge and note is that there is a passion and enthusiasm to address many of those things that you've highlighted. And thank you for sharing Catherine's story with us today. It's hard to come back with positives when you hear how those things have happened for Catherine, and they're absolutely not what we would have wished. However, I think it drives me and I think it drives us to do better and to coordinate. And as Ian rightly said, nobody failed for their bit of it. It was more about how we do it together, which I think absolutely makes the case for the work that we've planned and we're embarking upon on our neighbourhood journey together. So, following that sober piece, I'd just like to invite Emma just to say a few words as a small example about something that we are doing. There's lots of micro examples across Norfolk and Waveney and Suffolk that's some good work that we're doing to support people and individuals. So Emma, if you're happy just to share some of it, please, that'd be great.
Yeah, thanks so much. And so it's difficult to follow that, isn't it? And one of the things that I'd just like to add is, Ian, I don't have all of the solutions. It's people actually on the ground that have got the solutions. What I've been able to do is help unlock some of those with the infrastructure that I've started to work with. So one of the most simplest things we've actually done as a team is actually spent time out in our communities. So in particular, there's 2 of my team that are working with a GP practice who's represented here today. To actually get to know the population, not just what's on the data, what we get back from insights of district councils, but to actually get a real feel for what's happening for those people, where do they tend to go. What we're seeing, and again, we've just heard from Kat, there's an MDT where we know if we looked at policy direction, that's another thing that should be instrumental in our system, but it's clearly not working. The reason why it's not working is that staff haven't been empowered to work differently within those MDTs. So one of the biggest bits that we're able to offer, and this is all coming from a learning approach, we've not said these are the aims and objectives that we want to do. We just want to go and work a lot more closely with people on the ground who are doing this day to day to try and make it easier for them to help deliver those outcomes for people. So what we've done is we've listened to what people have said to us, the workforce. So actually we're kind of starting to realise that one of our most powerful enablers is our workforce, but we possibly haven't unlocked them to work in that most effective way when it comes to making those differences. The reason for that is there's usually a policy that will guide their work, there's usually a pro forma that might guide their work, and an operating procedure. And all of that is about safety of that worker. Now, I know Ian's a huge advocate. If it's not illegal, shall we go for it? You might have termed it slightly better than that, Ian, so I probably haven't done you a great service there. But actually what we've done in the room with those workers is said, what's stopping you? And when we hear, well, we're used to doing it in this way, it's, well, let's see what happens if we do it differently. So we've not had to create massive service specifications. We've not had to create different commissioning solutions. What we've done is actually heard people on the ground what could be done and actually started working with the willing. Actually, what we're doing from that is then learning. Those people on the ground are developing confidence in working with one another. So again, something that Ian mentioned earlier, we've gone from tasking someone else that you might not even see on a monthly basis that sits in another building to do the next piece of someone's journey, is actually getting them to speak to each other. It's taken that tasking out of the way. And you know what, next time they come up with a possible challenge or a need, they'll be able to reach out to them without having to worry, what will I get or what won't I get? So all we're seeing is an exploratory avenue through actually when you do say to people, well, let's give it a go. Let's see what could happen. Great things can come from that. From the workforce themselves, we're actually seeing a huge amount of confidence development there. And as soon as you start to put the confidence towards the workforce, actually they then generate that ripple effect of what comes next. So again, I don't then have to go back into my office and then start to develop the next service specification or anything to say, well, what happens next on that journey? We don't have to rewrite that pathway for it to happen because the people on the ground are already making it sort of happen. Is that easy? Not necessarily. What it does mean is that we have to commit time into that space to allow the workforce to operate in that way. But what I'm seeing time and time again from the example in Anglia Square that we've got is there's huge appetite out there to do differently. No one goes into work and says, I don't want to do a good job for anyone. I don't want to be stuck by these certain parameters. But it's those safety mechanisms through those operating procedures, policies that hold us back. Like I said, we haven't taken a programme approach to this. We've adopted a learning system. So we hear, we test out what that thinking is, and then we reflect on what's happened as a result of that. Everyone is involved in that learning. It's not an evaluation team necessarily doing it. Actually, everyone has the ability to share that experience and then feel, where do we go next? So where are we at this point? The team, I say a team, that it's more of a cultural way of working rather than just bringing people together for a meeting. It's allowing them those fluid connections on a more day-to-day basis and changing their sort of operational way of being able to do things. So where are we with that? Is they're making those great connections and then being able to work on the ground. Instead of getting people to travel to certain buildings, we've actually put some purchased some units in Anglia Square. So they're similar to a shipping container. What they will serve is they're actually in the physical location where these people exist. They're going to be hosted by multi-agency so that anyone can walk in, rather than maybe pay for a taxi for someone to come up maybe to this site in particular. Do you know what? That might not be a good day for them to get into that taxi because their mental health needs are so complex. And again, that's another appointment that's been missed. I know, again, talking to colleagues within general practice who, again, are suffering from people not turning up to appointments, how do we make those really accessible for them? So again, it's trying to meet people in their communities in a way that works for them. So again, thanks to NSFT, we've been able to mobilise a lease contract for those units so that they can work around a multi-agency. You'll see in the presentation that wasn't easy to get to that point. So there's a huge amount of things that could be done to help us accelerate as a system in terms of our shared working as partners. But again, we're not being put off by the normal constraints of how we would work. Couple of other things, if we're afforded the time, is got to the point of one of the other things that I'm sure all of those workers were really familiar with was working on different systems, recording information on different systems, and only part of that being able to be shared. So we're at the stage of hearing that from the colleagues on the ground, is that they can't see what's happening, don't know where care is being coordinated, who's actioning what, and each professional will record it in their own system. So we're going to do a piece of learning. So we've got a digital system that's built off the back of the shared care record that's prepared to work with us. They will look at joint shared care plans. And it isn't about trying to fill in another box, it's about trying to enable that story to be held once for multiple agencies to be able to access it, see what's happening, and that's under development at the moment. For anyone that is hoping to attend the Expo event, we'll actually be bringing the system along, so the company that are providing that, you'll be able to see a little bit more. We'll be sort of hosting a bit more information about exactly what's happening on the ground. Just one last thing that I would say, if that's all right, is that this is not unique as pockets of activity that are happening. We've got other trial areas that are happening. And again, what I would just reinforce is that's all coming from a coalition of the willing. That's not about a commissioning intention or a commissioning intervention. That's going out and enabling people to work together on the ground. The role of the ICB in this has been about facilitating and convening and allowing. we've not had to do anything more than that. So it's definitely not ICB-led. It's actually just enabling those people on the ground. And if that's some way that we can help towards that, that feels like a really good commissioning intervention to me. So thank you.
Thank you. And I want to leave time for questions, so I'm going to say very few more points. But again, a big thank you to Kat for sharing the personal story and experience of Catherine, and to Emma for the work that you and the team are doing. I think we've heard the case today for why this is important. There are lots of things that are happening. This isn't a structural reorganisation. This is about how we better align our leadership, planning, commissioning and delivery. And I'm pleased to report that our plan, and hopefully Ian will support me in this and colleagues from Suffolk, that I feel we've made the right steps on this journey. We've set the case out, and I'm excited about how we can make improvements in this area. So thank you, Chair.
Mark and indeed colleagues, thank you very much. I think you can probably see how impactful your presentation was, Kat, and thank you for Catherine's story. That's had an impact on us all, hasn't it? But of course, more importantly, on Catherine, and perhaps a great example of how when something is everybody's problem, it becomes nobody's problem, and that's what we've got to avoid. And I notice on your last slide, which is still up, that Catherine didn't fit the system. We've got to be smart enough to hide our wiring, haven't we, for the benefit of the people we serve. So thank you so much for that. I'm going to go for questions, though. So first of all, if I start with Elaine, and then I'll come to Lisa. Elaine?
So yeah, thank you very much for going through the case study. I think that, you know, was recognisable from other experiences I would say I hear from people, but it really brings to light the complexity and also how it's not working, and motivating, therefore, as Mark was saying, to make sure we get it better. It does sound like at the moment there's a lot of the work, Emma, that you're describing is kind of evolutionary in the learning. I like the fact it's not a structured programme approach. What would be sort of helpful to understand is if you've got a sense yet of, though, how we would know it's working at scale. Because obviously you can look at individual cases, but you know, as Kat's saying, this is not unique. So have you got any thoughts on how we know that this is going to work, it's working actually at scale and it's having the right impact for people, it really is impacting them in the right way?
Yeah, so I guess there's two elements. There's one around the cultural thing, so the conditions have got to be right. So again, it's about creating that safe space for a workforce, so that we can do on scale, but that isn't, again, an ICB-led initiative. That needs to be whole system initiative. And then I think there's associated with that is all of the enablers. So you will have experienced here about policy changes and interfaces between some of those things. We know already some of from years of experience around the GP sort of secondary care interface is complex. For example, we've just brought geriatrician into a multi-agency environment. I'm not calling it an MDT because we're not, again, putting a structure around it. We're trying to learn from that. What we're seeing in that is that we hadn't foreseen if we'd have taken a programme approach, because we'd have had some really clear aims. And I'm not saying get away from programme approaches, because there's a real good value and a space for those. But what we wouldn't have ever foreseen is the amount of de-prescribing that could come from that initiative. Now, what we've learned from that, say, for instance, is that a GP may not have the level of confidence around some of that medication and prescribing to adjust that. That would have then required the patient to have to go back in contact with the hospital. So there's something that we're seeing through that multi-agency. Again, these are all where we're looking at frailty, so we're taking a data-led approach to each population or each geographical area as a just what's the inroad, if you like, to start that learning. But you could apply that type of working to any sort of, however we cut our work, whether it's by condition, population, whatever, we're trying to create those conditions that will allow. So, yeah, we've got learning from each of these different environments, but we're not trying to be too rigid on what the route in is.
The other really powerful way of answering your question is to look at system resource consumption pre and post relational intervention. So I set this up or a similar approach up in a former life in Essex, and we mapped 46 residents who had working age adults with complexity, pre and post. The first 5, you need to get data sharing agreements between the organisations to do it, so it takes a bit of time to set up. The first 5 on the 110 days prior to intervention consumed £1.26 million of public sector resource, and in the same period post-intervention consumed 62,000. We found over the 46 it was a saving of about £56,000 per resident per year. It's irrefutable. We have massive failure demand in our system, as Kat outlined in terms of the MDT she was in this morning. Not only does this deliver better outcomes, but it saves shed loads of money as well.
Better outcomes and better use of resources. Thank you, Ian. Do you mind if I keep moving, Mark? Is that okay? I'm just conscious of time, colleagues, important though this subject matter is. Lisa?
Thank you. I guess I'm struck by how Kat's team was the only team that did see the person and not the service, actually, and how you provided that continuity of care model as the central people for Catherine, and we know how important that is to people. You talked about 2 things that I think are really important: that culture of professional respect towards our care staff. And interestingly, somebody the other day that works for a care agency asked me for an NHS lanyard. And I said, why on earth? You don't work for the NHS. But I'll be respected if I have an NHS lanyard. So that's really interesting, and how that culture change and how you have pride of place in those MDTs and are seen as important as everybody else. And then the whole bit about eligibility and the culture of eligibility, because the professionals that we're bringing together in the neighbourhood teams have worked in a system of eligibility, haven't they? And how, I'm really curious, and it's, we could probably talk about this for hours. I'm really curious how we shift that culture change from one that our staff have kind of grown up in, which is about, sorry, you don't meet my criteria, and how we do have to do that as a system. Otherwise, we set our frontline practitioners up to fail, because they'll be doing something different to what we're asking them to do corporately. But it's a huge, huge endeavour, but huge, and thank you, Kat.
Thank you, Lisa. Do you mind if I take Lisa's points as, I saw so many nods around the table as, and the points being made as rhetorical, but also that culture change, Lisa, it starts here, doesn't it? It starts here with us collectively and every single one of us, the commitment to make that change. Agreed? Thank you. Ed?
Thank you, Kat and Emma, and indeed Ian. It's really, really powerful. You've talked about relational practice and culture rather than services, and I'm going to make a comment about services, so I understand that I'm off beam. But Catherine's story, you talked about the amount of urgent care she requires, and in the paper, page 24, there's Brian's story, where he's consuming an enormous amount of urgent care too. We've commissioned in Suffolk a care management service which is aimed at supporting the 1% of the population that are using the most amount of urgent care. So I think as a board we need to make a decision in the coming months about whether that service should be extended into Norfolk as well or not, because we need to get behind the relational practice and the grassroots and all of that leadership development, but we've got to think strategically about what is the service response to this, so that people in this situation get extra support, and we are actively trying to signpost, navigate, sort these issues out, be kind. So let's just kind of think about the service bit as well as the cultural piece.
Ed, would it work? Would it make sense if we as a board asked EMT to look at that? Would you look at that through EMT and come back to a future board with recommendations, conclusions and recommendations?
And just equally in the other direction, we've agreed to pursue an integrated frailty service for Norfolk and Waveney, which, given our our population, that's an obvious thing to do and it'll be very effective, but we need to make a decision about, is that Norfolk and Waveney and Suffolk, or just Norfolk and Waveney? It seems to me we should be doing things once on that scale, but there's some big decisions we need to make.
Okay, thank you very much. I'll come to you, I'll add you to the list, David. Let me go to Janet. Are you done? Thank you. Tim?
Thank you, Chair. I was just going to reflect on Brian's case study and also, obviously, what Kat has just talked about. I think just to really highlight the importance of that non-clinical relational support, and those roles need to be well reflected within integrated neighbourhood teams and MD teams and provided with some parity. I think strategically we need to think about how these are embedded in workforce planning as well. I think that's a really important part of what we're trying to do, and agree completely with Ian's point around we need to do something different, and it needs to be a very different approach from what we're doing. I think we also then need to consider that case management. So what Kat was talking about who's the most important person in the room. Kat would have been knowing knowing Catherine and being able to provide an overview and holistic support, I think is so important. So it's how do we put people like Kat in the centre of that MDT to help almost coordinate the care that's needed, so that things don't get lost. I think reflecting on the wider paper, and in terms of what we're going to be doing in the future around integrated neighbourhood teams, I think one of the asks from me is just that we don't rush into making decisions around integrated neighbourhood teams, and we think about who needs to be on them in each neighbourhood, around actually they reflect the needs of those communities, and that we think very carefully about which one, because each neighbourhood and community will look differently. Thank you.
Thanks, Tim. Again, I'll take that as agreed. I'm going to go to Amanda, Kirsten and David, and then I think we really need to wrap on this one. So, Amanda?
Thank you very much, Chair. So my question is for you, Emma. I was really struck by what you said, particularly the references you made to our workforce. So as a board, do you think there is one thing that we could do that would have impact to address what you've said? One thing. One thing,
Emma, that's a challenge. Over to you.
I'll phone a friend. No, the simple thing is about enabling people, giving people permission. And I think we're so used to creating a form that follows the conversation that you'll have. We'll transact that into an output, into a financial equation as well. That, yeah, I think that's what has then shaped practice. So the more that we can help people feel okay with doing what feels right for the person, I totally get there's about, making sure that the quality is aligned and professional practice is still upheld, but there's that barrier, not barrier, but I think there's some blurring between that would be really instrumental in helping people build that confidence in that space.
So an enabling culture, Amanda. Thank you, Emma. Kirsten?
I think that just covered the point I was going to ask, actually, so thank you.
Oh, that's excellent. David?
Yeah, it's on the same sort of theme, really, and Ed picked it up, and we talked about this enabling, because we're at that stage where people work in a particular way, and we don't yet have the momentum and scale, so we're dependent upon an alliance of the willing, and most of us recognise that an alliance of the willing isn't quite as strong as direction and us as a board enabling something. So I suspect we have to specifically take some of this scarce resource, which is currently being used by acutes, by the community, and we have to say that resource is now going to work within this area or with this group of people to demonstrate and to prove that this is the best model for the way forward. And I think if we don't do that, there will be competing requirements on business as usual resource versus this really important area that we're talking about here. So I think the enabler we need to do as a board is to ring fence and to specify that these group of people or these professionals or this time will be used to work in this way.
Can I just come in to try and answer, because your question was kind of too good to miss out on, but I'd maybe say three things rather than one. The first is there is something about systems and processes and how we're assessing or our IT infrastructure, etc. Can we realign those to be more relational? But that is probably the least important. There is certainly something actually, and you alluded to it earlier in your really powerful presentation, which is about actually locating professionals together physically. So we stop making, so relational practice works not just between a professional and a resident, it works between professionals. So the power of informal relationships, when you co-locate professionals together from multidisciplinary teams and you encourage them to start working relationally with each other, you stop that onward referral. The third one is it's not enough just to give people permission. You've got to give them the skills and the ability as well. And people have been locked in this eligibility. So to answer your point, Lisa, there is something about a comprehensive OD programme. We're setting that up in adult social services at the moment, and we're launching that. I think there's a huge opportunity to do that jointly with the ICB and the NHS more broadly. I know, Ed, you are keen on a kind of an academy approach. I think there's a huge opportunity for the board to endorse something like that.
Ian, thank you very much. Mark, one last quick one.
Very quick one, thank you, because everyone's done the speaking for me, which has been fantastic. But no, not at all. But a GP colleague summed it up perfectly for me. We're talking about integrated care, joined up care cap. And a GP once said to me, I knew we'd cracked it when the social worker had their coffee mug in our coffee cupboard. And it's not rocket science, this. It's, I think we're in a really strong place now. We've got the plan. We've brought partners together. It's now our opportunity to make the real difference. So thank you.
Mark, thank you very much. And colleagues, particularly team, for the presentation. And you can see the impact you've made. Thank you for the actions agreed, which Tom will have captured and Heidi will have captured. Thank you very much for that. We look forward to EMT coming back to board on this, capturing the issues as discussed. We're actually asked in the agenda only to note this item for information, but actually I think we're supportive of the actions as agreed. And in fact, in the paper itself, on page 23 of the pack, there are 3 recommendations. First of all, to approve the continued system-wide shift towards neighbourhood-based ways of working in line with national policy and local ambition and so on, to endorse the progressive alignment of leadership, the way you've discussed, governance, planning, commissioning, rather than defaulting to the organisational approach, and then finally agreement to design neighbourhood delivery as a learning and relational system. Are we supportive of all those recommendations, plus the specific ask on EMT? Agreed? Thank you very much. Thank you all. Thank you, team. Now, so I'm already in trouble because we're running 12 minutes late, but I think that was well worth it. I'm going to now go to Richard for the Norfolk and Suffolk response to Jim Mackey's letter of the 1st of April 2026. Over to you, Richard.
Thanks, Will. So you'll see in the pack, as Will's just described, our response letter that we submitted last Friday to NHS England following Sir Jim's letter out to both ICB and NHS acute providers. So Jim wrote about 3 weeks ago, effectively at the start of the financial year, to set out some of the stall of NHS England, but particularly to ask local systems effectively 4 key questions that you'll see within this letter. We decided, I think collectively, that it was more powerful to write a joint response back across the different constituent parts of our local system who would receive one of the letters. And hopefully you'll see in the pack, I think, quite a powerful and consistent narrative that we've come together around. I should say that Neil Maloney, as Chief Executive of the Ambulance Trust, has also signed up to the letter, so that was a later signatory. And the letter itself went to the first meeting of the Strategic Commissioning Committee that Will and Ed alluded to last time, where we went through that in some depth and had quite a healthy conversation, didn't we, Fanwell? I won't go through the letter itself in any depth, just to pull out the key questions. So what strategic commissioning means to your local system and how you intend to develop that over the next 3 years. So that really followed our submission of our strategic plan and our strategy, but we've pulled out further some very specific details of the kind of work that we're looking to do in the new guise of being a strategic commissioner within the system. The second question very much actually relates to the item that we've just been through. So the question is really, what's our ambition and our plan around neighbourhood care in our local patch? The third question relates to changes in financial flow and payment systems that Howard led on. So that was particularly where NHS England were asking us for any ideas and thoughts around changes that we thought would help achieve what we've set out within our strategy and our plan. And then the fourth question was a bit of a catch-all, really, to say, were there anything else that we could do, or the centre could do, NHS England, to help us deliver our plan? So hopefully we've come up with quite a well-balanced and evidenced response. We've not got a clarity yet quite on what the next steps are, but we were expecting some kind of response through from NHS England, hopefully in the next few weeks.
And indeed, we'll keep the board informed if and when we get said response. So, colleagues, you've seen this before, and a lot of you have been engaged in detail on it. And Fanuel, thank you for taking it through committee. Any specific questions? Otherwise, we're asked to formally note. Ed?
Yeah, well, I think it sets out a really great manifesto, if I can use political language, doesn't it, of what we're aiming to do. I guess my point is that obviously it's been signed by all the partners, key kind of NHS partners, which is great. But will this letter go through their boards? Because I think it would be good to sort of share the manifesto widely so that everyone's clear what we're trying to do over the next 3 years.
Yeah, that's a very good suggestion. Can we take it as an action to prompt said CEOs and chairs to bring to their boards? Agreed? Thank you very much, Elaine.
Just a couple of comments. First of all, I thought it was an excellent consolidation of a lot of the documents that we've reviewed at this board before, so I thought it was really good to be able to put those together. I think my second comment was just it would be great if there's an opportunity for us to learn from other ICBs, how they've submitted into it, because it's obviously quite a shift we're talking about now, and actually it would just be great if there's things we can learn from other ICBs as well.
Yeah.
Yeah, I'm happy to pick that up with NHS England. I will be looking at the letters with my other hat on, so if I get any insight, and so will Frankie, so if I get any insight, I will feed that back as well.
Thank you, Richard.
No red pen.
Oh, sorry. Yeah, no, absolutely. Frankie?
I think it's probably worth just reflecting the missing signature. We did share this with primary care as well, but it is a little bit more complex, and the timescales involved. The appropriate federations didn't feel able to sign it at this stage, but with more time and with work, I would very much hope they'd be behind us too.
That'd be useful, wouldn't it? Yeah, okay. Good. Thank you very much. Leslie?
Probably just want to make a comment and then potentially ask for us to consider something. The comment is this is the first time for us that this has happened where we've actually all come together as various partners and been able to agree what our collective response and therefore accountability will be, which leads me on to the second. I think we do have to consider, we do come together for various things, whether it be through the executive management team, etc. We should not make this, we have put that in and then we'll just review it occasionally. This really needs to be what continues to bind us together, and so that in fact the way that we meet, what we discuss, is around making sure that this is what happens. So I think that would just be a consideration, please.
Yeah, good point,
I
Richard.
would absolutely echo that, because I think otherwise it just becomes something we did and then we send it in and then we don't actually action it. And I think given that we're looking to bring together, I think, a chief execs forum across the organisations, this could, I think the phrase you used, a manifesto or a set of commitments, that becoming we're mutually bound together around delivering what we've outlined in the letter.
Yeah, thank you. And Ed kept saying yes while you were speaking. So.
Well, we were on the same page, I know, but and I did think about the previous item on neighbourhoods, is we need some really hard-edge accountability, because with accountability you get delivery. So it's just, with all of this, we're all saying the same thing. We need to take it really seriously and hold the mirror up if we're not progressing.
Absolutely. So, noted, supported and endorsed, and the beginning of a story which will develop further, possibly some further actions to come with new signatories. Keep us posted. All agreed? Thank you very, very much. Thank you, Richard and colleagues. Item 9, the Suffolk Annual Public Health Report 25. Stuart.
Thank you, Chair. So this year's Suffolk's Annual Public Health Report focuses on younger people. And obviously Lee's here talking about older people for this year's, but we also did that last year, so it's coming together in the report there as well. And I suppose just a brief point about why on young people this year, and particularly focusing on secondary age children, is there's kind of two aspects to it. I think one of them is about trying to help support reframing the narrative, and Ian was talking earlier about strength-based approach, and the fact is that much of our dialogue around young people at the moment is about what they can't do and what the issues are, whether it's the increasing mental health problems, people not being work ready, and that's the dialogue that kind of plays out a lot. Actually, through doing this work, what we found is there is an incredible bunch of young people across Suffolk who are doing amazing things, which we don't necessarily talk about, and we don't help to feed into that wider thing about what's possible to do. So the idea of focusing on this was, one, to reframe the narrative, and also we often focus on rightly on the best start, particularly the youngest age, but actually another key developmental age group is in that secondary year with brain development, social development, everything else. So for me, it was about trying to just step back and look at something differently. So the report is based on using the approach of youth social action. And often when we talk about co-production, we talk about it in the sense of we're bringing people together to help inform something. I think what I've become clearer all the way through this process is that actually youth social action is an intervention in itself. Because actually bringing young people together to empower, to make decisions, to come together to solve problems, provides connection, provides purpose, and actually the young people coming together to support this report and the work we go forward actually are getting a great deal more than just trying to help find a solution to something. So for me, again, it comes back to that cultural point we mentioned earlier, actually, that this is a way of thinking and working, but actually empowering young people to do things and giving them resource to do that is a really important part of it. So to inform the report, we did 3 youth hacks across Suffolk. And again, the principles we used was for young people, by young people. So the hacks themselves were facilitated by youth ambassadors. The journalism coverage was done by youth journalists who were aligned to one of our local media outlets. The videos for the report were recorded and edited by young people. And then when we did the launch of this at our Health and Wellbeing Board workshop, there were 70 people there, of which 30 were young people, and then there was 40 adults. And actually, it was incredible to see the dynamic change, to actually have conversations with these young people actually quite happily taking the mic and actually doing the leading. And people came out from that feeling really empowered. The risk is now is, so what do we do next? But actually, a really nice anecdotal note was somebody drew a picture in their evaluation form saying this was one of my best school trips I've ever had, which is not what I'd normally describe maybe the Health and Wellbeing Board as being one of those things, but again, it changed the dynamics that they were actually driving some of this work. So youth social action in Suffolk isn't something new. In Ipswich, which is the first town of youth social action, started about 4 or 5 years ago. But the ambition here is about scaling this up across the county. So just briefly, what do we find from the hacks, and what are the actions that we need to do? I think the first thing to say is young people are very wise. One of the first things they said was that mental health depends on connection, not just services. And one of the discussions there was around digital. We often make the assumption that young people want to use digital and we need to do everything from a digital format. What's coming back from them is that you're kind of forcing us to go into digital because there isn't any resources in a rural county, and actually it's the only way we communicate. We quite like meeting up. Now that doesn't fit everybody. Everybody has different needs and different requirements, but there was quite a heavy pushback of, can you stop making these assumptions? The second one was young people need safe, welcoming spaces. And again, where can young people come together? And necessarily they didn't want events put on, they wanted places they could come together to meet, to talk on their own terms around that. And then the third key point they picked up was that systematic barrier, and this will be the same across Norfolk and Suffolk. Clearly, transport is a huge issue, and that opportunity to be part of something and to be brought into something. So from an actions perspective, the discussion was, yes, we need good services, but also we need investment in the opportunity to connect people. And actually, some of the things that came from one of our more recent hacks was, again, about young people wanting to do some peer work around mental health and well-being, and that actually being able to come together to talk about their own issues and challenges and working together to do that rather than a service-based approach. About supporting local infrastructure, and we talked about the importance of coalescing staff and working in neighbourhoods. Again, creating spaces that young people to come together to mix and understand each other. A really strong point was around amplifying youth leadership. I mean, that Health and Wellbeing Board was a revelation. I'd kind of wished every Health and Wellbeing Board was like that, because there was far more energy, but also there was some really practical grounding in there about what's important to young people and what we can do. And the final one was about increasing that access and inclusion. And I think what's really interesting is that the young people involved in the 3 hacks we ran for the report, actually the different mixture of people there, because they were there on their own terms. They wanted to do something they were passionate about, and that involved people who are neurodiverse, from many different ethnic backgrounds. It was interesting to see the different mix of people. So I suppose the ask from this is that we're trying to set up a community of practice and building what's been done in Ipswich about how we can use youth social action more as an intervention across organisations. And one of the things we've done is also brought private business into this. The finance director of Medici Shipping came along to one of our hacks and was blown away with a room full of youth entrepreneurs. So we're saying that people aren't ready for work, but actually there's tons of young people with lots of ideas. How do we harness this? So we've got a number of businesses involved in this, but I think it's about how we all in this room can lean into this with the assets as us as anchors that we have. We are going to run a further series of youth hacks across the county. We managed to get some funding, so match funding from Suffolk County Council and the Lottery Fund, about 400,000, to both put on those hacks, but most importantly, what young people have said is, you never then give us any resource to do anything about these things. So there will be money coming with that to actually implement things in their communities. And young people actually know what's important. They're very localised in their view. They understand where they live and what they want to try and do. And we're going to work with VCSE to deliver that. So I think the ask is really, how could you as organisations come and be involved in this? Very much come in and witness some of this as well, because the stories and the information is fantastic, and I think it can help inform how we work in the future. Thank you.
Stuart, thank you very much. Kirsten?
Thank you, Chair. Thank you very much, Stuart. As you know, I'm very supportive of this and the fact that you're working with the voluntary sector. Stuart came to the Suffolk Voluntary Sector Assembly and spoke about this as well, so people are well versed on it. And you'll see in the document that volunteering matters have been really key to this particular piece of work. I think I just want to commend people to work with the voluntary sector. If you really want to work with people, this is where we come into our own. So it's a really good advert for us. Thank you, Stuart.
Thank you, Kirsten. Elaine?
Yes, really supportive of this, actually. I thought it was a great paper. I wondered if you could just expand a little bit on the cohort that you're hoping to address. And particularly, I noticed at one point, it talks about some voices aren't heard. How you can reach out to those that are maybe less open about coming forward, and also then addressing inequality, so how you can best manage that.
Thanks, Elaine. I think there are a couple of points there. I think one of the first things to do is, if you need to be doing things on the things that young people are interested in. One of the feedback was, you always want to come and talk to us about mental health and knife crime. And actually, if you talk about and give them an opportunity to work on the things they want to work on, actually you get a different group of people coming compared to what you would if you start to set the agenda. It's a relational practice again, we're going with what's important for them. I think also, though, we need to recognise that we do these in slightly different ways. So focus of this work going forward will be geographical, but I also think there'll be communities of interest we might need to look at doing differently. We might need to do some stuff online for young people that maybe aren't comfortable or confident coming into a bigger group. So the next stage enables us to scale that up further to do that. But I think across, when we do this, we're going to be looking at the different groups that are picked up by that and making sure. But we've been also doing it by working through local colleges. So volunteer matters have been hugely important for this, but actually the local FE colleges in Suffolk have really got behind this, and actually they're often working with young people, particularly those that might be NEET, that maybe struggle through other forms. They actually focus this work on those groups, because actually it's a way of engaging and learning together that maybe isn't seen as being formalised, but it's part of education and learning. So I think it's as much about which partners we work in to deliver that, rather than thinking that we know all the people we need to go and talk to.
Okay, thank you, Stuart. Lisa?
Thank you. Thanks, Stuart. It's got kind of strong alignment with the values and intent in the National Youth Strategy as well, which is really helpful. The joy of working across 2 counties and with different organisations is you can sometimes see where things work really well in one place that can maybe help the delivery in another. And we've talked a few times in Suffolk about that Children and Young People Strategic Alliance and that partnership strategy. And seeing how it really supports in Norfolk to deliver the strategy, and it was the Alliance meeting this week, and seeing the voluntary sector, everybody, Tim, I think you were there, and there was lots of people there from different organisations, and everybody understands the strategy and really is in kind of one sort of mindset of delivery, and I think that would really help us in Suffolk to kind of create that infrastructure for delivery.
Go on, Stuart.
I can completely agree. I think we are looking after the summer for the first around it, and I suspect 2 priority areas will be the youth strategy and Best Start, which are very much about a wider thing than just local authorities and the NHS around that space.
Okay, thank you both. Tim?
Yeah, thank you. I just want to say I think it's an absolutely brilliant report. I think it's really nice to see. I'm trustee of a youth charity in Norwich, in Sprowston, and so for me it's great to see the youth voice amplified. I think both the Suffolk and the Norfolk report that Lee will talk about are both absolutely fantastic and have some fantastic recommendations. I suppose for me, I think there's 5 recommendations in 2.6 that this report makes. And I think they're just quite simple, straightforward recommendations that would apply to everything that we're trying to do, I think, today. If we think about what we've just talked about neighbourhood, if we think about what's in the report that Lee's going to talk about older people, it's exactly the same. If you take out young people and you put in patients, or you put in carers, you put in communities, they're exactly the same. I live in Lowestoft, a youth charity, stopped delivering some services in March 2025, and in the last 18 months, if you look at Lowestoft News like I do, you will see that there's been an increase in youth violence, there's been an increase in antisocial behaviour. We now have a public space protection order in place. No one's quite linked that back to the fact that we've lost connection, we've lost services. There is no local infrastructure for young people in that part of Lowestoft. When we talk about neighbourhood, I talk about community infrastructure. This is exactly what we're talking about when we think about community infrastructure. And just thinking about then what the opportunity of that infrastructure is to bring in then health and social care services and other services to help support young people. So I think there's something for me about we need to take the recommendations that are in this public health report, change young people, and just make sure that we keep pushing it into the different narratives that we're talking about, all of these meetings. Because I think if we do all 5 of these things, regardless of who we're talking about, we'll be really, really successful. The only thing for me, I think, is that we need to make sure that we enable this report and the recommendations, that they go out to the right places. They need to go out to health and wellbeing partnerships, they need to go to place and alliance structures, they need to be involved in what we do in terms of neighbourhoods, and we also need to be really strategic in thinking about how does this align to the funding that is coming into our communities. We're really lucky that Pride in Place funding is coming to 8 different regions within our ICB. So how are these recommendations, but in both reports for young people and for older people, being embedded in those Pride in Place boards? I think it's really important that we try and integrate some of this, but yeah, so I've waffled on a wee bit, but
Tim, thank you. Do you want to comment on that, Stuart?
I think it's a really helpful comment, and actually something that I did also make the comment about the similarities for the report last year for the ageing population. It was very, very similar but slightly different framed points. And it sometimes comes back to the strategyitis that we talk about at health and wellbeing boards, that actually what are the fundamental things? And I suppose the key thing is what's important to our lives. As previous Chief Executive of Public Health England is a job, a friend and a home. And some of those principles are very similar across this. And again, it's very much in relation to the previous item as well around what's important for people. So I think the Pride in Place one's a good point. I hadn't really thought about it in that way, but we're happy to take it out on the road where need be as well.
Great, thanks, Stuart. Fanwell?
Thank you, Chair, and thank you, Stuart. I think having attended some of the hacks, I was equally, quite surprised with some of the insight that came from the young people and the intelligence that you talked about. We've heard today from a number of presentations about this sort of coalition of the willing, but I think we've got a real opportunity here, looking at the strategic commissioning role that we have, because one of the, part of the requirements there is how do we evidence that we are doing right by our communities, particularly in terms of how we're using that insight to inform the way we commission for services and we deliver services. Now, youth social action programs can be quite instrumental in terms of us, providing the evidence that here is the insight that our young people are providing us in order to, and I think there is going to be a requirement for us to show how our services are different or better as a result of that insight that we're getting. So I think, it's not just a nice thing to do. I think it's a must do. We need to be utilizing this to inform how we do things.
Well, thank you, and very well articulated. A must do, not a maybe when we're ready. A must do. Stuart, I think you probably gather that you've got great support for this around the table, so thank you for that. We're asked to, and I think I'm going to assume that we agree this, support the continued development of youth-focused, co-produced, community-centred approach, which again, as a number of you have said, ties into the previous item very nicely. All agreed, and all those who can and want to help with this, Stuart, they can reach out to you directly, can't they? Excellent. Thank you very much. In which case, if there is no more, let's move on to Norfolk, the Norfolk Annual Public Health Report 2025. Lee, and welcome to the meeting.
Thank you, Chair. And I should just point out I'm here on behalf of Derek, our relatively new DPH in Norfolk. And you may have noticed that it's actually penned in Suzanne Meredith's name because it was published when Suzanne was our DPH. So I can't say that we had such an innovative approach to the content on this, Stuart, so there might be some learning for us in Norfolk for our next one and Derek's first one. But this, we took the report to our Health and Wellbeing Board back in March, and then very kindly took the opportunity to bring it here as well to have a discussion. So as we've already talked about, this report focuses on healthy ageing, and it was really challenging to scope because it's such a broad-ranging topic, and we could have quite easily probably had double the content that we had in here. But the one piece of feedback that I think I've had from colleagues and partners that we've taken this out to, so it's been to health and wellbeing partnerships across Norfolk, is that whilst it is very broad, it's actually really helpful to have all of that content in one single place and a kind of narrative that runs through it. So I'm sure it's not news to you that we have an older population than average in Norfolk, and the first sort of start of the report really opens looking at over the next 15 years, what's that going to look like for us, and in real numbers that's an additional 82,000 residents by 2040 that are over the age of 65. And that should absolutely be something that we celebrate. In Norfolk, 4 in 10 of our workforce are over 50. Big proportion of our volunteers and unpaid carers are also over 50. They contribute huge amounts to society locally and nationally. And it's really unfortunate, therefore, that almost half of over 50s report having experienced some kind of age discrimination over the past 12 months. And so I think hopefully a golden thread that you may have seen through the report is that sense of really thinking, how do we tackle age discrimination and the multitude of opportunities to do that as a system. Ageing isn't experienced equally across Norfolk, and whilst we have a better life expectancy than the England average, when we think about healthy life expectancy, which I think is some of the conversations we've already had around this table, we're no better than the England average. So very much again the focus about this is how do we add life to years rather than years to life. And how do we think about those cohorts, our most deprived areas or particular characteristics of our population that are essentially having unwarranted variation in terms of their healthy life expectancy and their experience of services and life more broadly. And of course, from a sort of medical perspective, there's a multitude of conditions that contribute to that, and very often it's more than one. So again, we've talked about multimorbidity already, and again over half of our 60-year-olds will have one or more long-term condition that's really influencing their health and well-being. So the report focuses across, tries to sort of apply three lenses, I suppose, to our ageing population. It talks about healthy communities, healthy people, and healthy places. And again, I think hopefully that I felt like listening to the conversation so far that really resonates in terms of relational practice and that point around a house, a friend, a job. And we absolutely looked across those domains. So looking at employment and social connections, the quality of our public spaces and how accessible they are. You may have seen some recent research around public toilet access potentially as an example of something that actually has a real impact on how usable a public space is. And of course those things that you might perhaps be expecting to see more generally in any kind of population health piece around vaccination and screening rates and healthy behaviours. Whilst there's a huge amount of national evidence and local insight that we've drawn upon, I wouldn't want to miss the opportunity to thank again voluntary sector colleagues and services that have provided an awful lot of input into the case studies that sit in this report, and it was a real privilege and pleasure to read through. We put a bit of a call out to system partners for stories and had far more submitted to us than we were able to include in this report to keep it to a sensible length. But it was amazing to see how much good work there already is and what assets are already there that we can build upon. So finally, before I kind of really happy to take questions and have discussion, just wanted to highlight the recommendations that are in the paper that we split into recommendations for residents themselves, recommendations for organisations as sort of single entities, and then probably most importantly those partnership opportunities and recommendations that sit within there. And also to say I think it unsurprisingly aligns quite closely with a lot of the findings and work that span out of Stuart's previous report in 2024. I'll stop there. Really happy to take questions.
Lee, that's fine. Thank you very much. And I think, as I said at the last Health and Wellbeing Board, it is a fantastic report. So thank you for that. Frankie.
Thank you very much, both Stuart and Lee, for really, really interesting and fascinating reports. I wanted to start by congratulating Lee, who has just been appointed as our Deputy Director of Public Health. So although Suzanne Meredith wrote this report, who we heard from at our last board, Lee has picked up the mantle, which is brilliant to have. So welcome back to the team. Secondly, I wanted to highlight one of the things I really loved about this report is that you've taken an asset-based approach and you're reflecting on the important contribution that older people can make and need to make and are making to our society, and I think that's really, really important. And the third thing I wanted to draw out is I really love how practical this report is, particularly saying, well, what can you do as a resident? Because so much of that, those years spent in ill health can be prevented. And there is something for everyone here. It is not too late. And a lot of the work we're doing already on cardiovascular disease prevention, supporting people to stop smoking, increase physical activity, we are tackling them. But I love the way you're empowering residents and you've included the links and you go straight onto it and you can see, okay, that's how I can get help to stop smoking. And equally, what we should be doing as partners and what each individual employer or organisation through the system. So I love the practicality. So it's not a question, it's just a rant in positive support.
Supportive rant, Lee. But yes, thank you for that, Frankie. And that's why it's a great report, isn't it? Yeah. Okay, any other questions or points? Otherwise, we're asked to receive a note, of course, and endorse the recommendations in the report, which Lee went through. And of course, in your own time, with your own organisations, to reflect on how these recommendations may impact on your own work. Thank you very much. All agreed? Agreed. Lovely. Thank you. Thank you, Lee. In which case, item 11 now, the Norfolk and Waveney ICB, as was, Research and Innovation Report 25-26. Welcome to Clara, but Frankie, over to you.
Thank you, Chair. So this is our last Norfolk and Waveney Research and Innovation Annual Report, but eagle-eyed among you will remember, of course, we're now Norfolk and Suffolk. So from here on, we will be bringing a 6-monthly update on the activity of our research and innovation team across Norfolk and Suffolk. I wanted to highlight before handing over to my colleague Clara that our work is absolutely in line with our strategy, and that's our ICB, Population Health Improvement Plan, and which hangs off that our research and innovation strategy, and that this is really about community-based research. Clearly, we have some fantastic research also ongoing within our higher education institutions, within our universities, within our NHS trusts, but this is really about the research we enable and support out there in our communities. And I'm itching to steal Clara's thunder, but I won't. I'll let her give you those highlights about the 2,000 residents and so on and so on.
Thank you. All yours, Clara.
Thank you, Chair. Thanks, Frankie. So I'm going to start off with two related things, if I may. The first is it's brilliant to be here on International Clinical Trials Day to celebrate all things clinical trials. And secondly, as part of that, I would urge all of you to sign up to be part of research, which you can do through your NHS app, which I hope you all have. So please do that. You can sign up to hear about research studies which you may be eligible to participate in and to contribute to the overall research endeavour. So that's my starter, my opening gambit for you all. So as Frankie said, this is the report for the Research and Innovation team from Norfolk and Waveney ICB. We have and we continue to have two statutory responsibilities with respect to research and innovation. So with research, we have a duty to promote and facilitate research across our system, but also the use of evidence in everything that we're doing within our commissioning. And from an innovation point of view, again, it's around facilitating and promoting innovation across our commissioning responsibilities. So we do have that responsibility for out-of-hospital research with a big focus on primary care. 53% of our practices across Norfolk and Waveney were research active in one way or another last year. There's a little bit of a reduction in activity, but that's due to the pipeline, and it's seen as something that's replicated nationally, so not very much we can do about that, apart from support our funders to think more broadly about where they might deliver research, which is much more accessible and equitable for our population, and we are doing that through a number of national routes. A couple of things I really want to highlight. One is our financial success, I suppose. We are a self-funding team within the organisation largely, and we host a number of NIHR, so the National Institute for Health and Care Research. We host currently 18 research grants, which are worth in the region of about £18.5 million over the next 5 years. And this is in conjunction with our local higher education institutions, so UEA primarily, but we also have worked with other colleagues across the country. As a result of that, that brings in some extra funding for us every year. And so we use that to fund the team, but we've also done a lot of capacity and capability building, particularly in primary care. And we've empowered and enabled practices that were not research active to think about it, to form networks amongst primary care networks, to become research active and to work together. And that's been incredibly successful. And return on investment of our investment with research capability funding, for every £1 we put in, we've got about an £18 return on investment. So we're really using it, I would say we're using it very well, and we're getting really good outcomes. What else did I want to highlight? Some of the new grants that we are currently contracting for at the moment, we heard a little bit about deprescribing earlier. It's really, really important, and we heard also how GPs find it very difficult to deprescribe and to initiate those conversations with their patients. So one of the projects we've just had recommended for funding, and it's in the contracting process, is about a toolkit to help practitioners to deprescribe unnecessary antidepressants. So that will be coming through. That's a sort of a £300,000 grant. And the other is around exploring risks for women who have pregnancies after bariatric surgery, and basically to inform their kind of future care needs, both during pregnancy and post-pregnancy as well. The other thing we've heard already today around community and the absolute importance of working with our voluntary sector. So one of the things I think I'm most proud of and my team are most proud of over the year has been our work as part of our research engagement network. And so this is NHS England funded, and the overall aim is to increase the recruitment of people from underserved and underrepresented groups into research. So groups where they've lost trust with statutory services, where research has not necessarily been something they've even thought about before. So using funding from 25-26 and also into 26-27, we are funding 5 community research hubs across Norfolk and Waveney, and these are led by our community groups. I've just had loads of messages from my team members today. They've been conducting their first group in West Norfolk this morning, sorry. One of the key things that we heard from that, it brought together 25 different community groups to hear about how they can support and participate and support their communities to take part in research. And they said they feel heard, which I thought was just such a lovely piece of feedback. They think quite often in West Norfolk they haven't felt as heard. So I was really delighted to be able to share that nugget with you today. And we recently recruited, there were 18 families into a study looking at type 1 diabetes screening in children. And they were recently recruited through a voluntary sector organisation in Lowestoft and Great Yarmouth. And we had another 24 recruited just this week in Thetford through the Polish school. So these are reaching out to groups that would never have had access to research or these opportunities before. So we're really, really pleased that we're working with lots of partners to be able to do that. Finally, and I think this might be what Frankie was alluding to, we do a lot of partnership work across our system. And one of the biggest successes we've had has been supporting the successful application for a primary care research delivery centre. So this is one of 14 primary care research delivery centres across England. It's based in Breckland, in the Breckland Alliance, and we provided some funding to help them write the application. We supported them with that, and now we're helping them with delivering research. They've seen a massive uptake just since January and in the last few weeks, with much more commercial companies coming. So we're going to have the opportunity and ability to share those new medicines and new treatments in the community where people live, really easily accessible for our population. So I will stop there. Thank you, Chair.
Clara, thank you very much. What a fantastic report and achievement as well, and self-funded. That was a really impactful statement. And also, I can't remember where it was now. We had a research. I came along to that research innovation event. It was somewhere near here, wasn't it? I can't remember where it was.
Barnum Broom.
Oh, that's right. Yeah, which was fantastic. And actually, it was standing room only, wasn't it? Absolutely terrific. Ed.
Thank you, Clara. You're doing a fabulous job. My question may sound loaded, but it is genuinely innocent. Possibly even ignorant. But so there's research capability in providers. We've got the UEA, University of Suffolk. Should we be consolidating more into a single function, or is it better to have it kind of distributed?
Do you just want to pop your mic on, Clara?
Thank you. I knew I was going to do that. The challenges of research in a single organisation on a single site, so in a trust, are quite different to that we see in our out-of-hospital settings. So I think there is a need to have a group of people and a group of organisations together that really understand what it's like on the ground. So we've been really advocating nationally for much. We're very lucky in Norfolk in that we have a dedicated primary care R&D team. That's not the same across the country. And so we're working with DH colleagues, with a couple of charities that we work with that represent R&D, to really think about how do we do that so it's equitable across the country. Where should that funding come from? Because it isn't the same everywhere. I think that there is a good reason to bring people together from a collaborative point of view, but I would say that the expertise and that we have from a kind of out-of-hospital primary care point of view work really well where they are, and actually having it, we provide that expertise across the east of England at the moment, so it's not just for Norfolk and Waveney. We work with our colleagues in Central East to provide the same service, that massive economy of scale that you get through working with just two really highly skilled teams to support out-of-hospital settings. And we do prisons, schools, care homes, all these other, it's not just general practice, pharmacy, dentistry, optometry, so we've got a real broad range and perspective.
Do you think she answered my question?
Well, I don't know. It depends how grouchy you want to be. Oh, is that it? Yeah. Got it? Good. Thank you, Clara. Tim?
Thank you. Yeah, I just want to say we know that research is really important because it informs the future. It informs what our strategy is going to be moving forward. It informs what services we might deliver and ultimately where funding might be placed. So I think this is a fantastic example when people say, how do we involve our VCSE colleagues and partners and the community in what we do? I think this is a fantastic example of how we can do that, and it's absolutely fantastic. We've worked together in terms of setting up some of the community networks, and it's great to see so many voluntary sector partners involved in the work. I think, you know, you alluded to, I think it was an organisation out in Great Yarmouth in Shrublands who they're now doing work around diabetes and bringing that in. And I think it just shows the strength of the voluntary sector in terms of able to bring community into some of the decision making. So it's absolutely fantastic to see. And I think it shows that we've got some fantastic tools that we can utilise. You know, it talks about the Community Voices programme, it talks about the community research hubs. And I think it's really important that we don't lose these and we really embed these in the way that we do strategic commissioning. I know we're looking at a strategic commissioning toolkit, so it'd be really interesting to see that we embed those in terms of the stages of commissioning and how we work. So yeah, I just want to say it's a really fantastic piece of work, and it's great to see the strength of the voluntary sector alongside research colleagues in such wonderful work. There was just one more comment that I had, I suppose more of a question, and it's not necessarily around the research element, it's more about one of the things that was highlighted within the report, which is the Community Voices project. I know that it's kind of been a little bit displaced in terms of our kind of new ICB structure, and there's a few questions around where that Community Voices project is going to sit. It might not necessarily be an answer that I might get now, but it'd be interesting to know what our plans are for that Community Voices project, where that's going to sit, and how we might enable that in the future.
Do you want to comment on that, Clara or Frankie? Mark? Oh, the debating.
No, it's right. I'll ask Mark to do that. It's in his...
Go on, Mark.
So I think the Community Voices initiative has been so valuable to us, you know, working with voluntary sector organisations, so it is still central to our plans, but we're thinking about how do we best do this across Norfolk and Suffolk now to make sure we get the best. As I've said before, many people don't want to speak to people like me wearing a shirt and a tie, so it's really invaluable that we do take that work going forward, but that is central to the plans. I think, Cara, you could attest.
Yeah, the Community Voices is where we started with our research engagement network. So without that, we wouldn't have really known what to do. We had 3 months to go and recruit more people into studies. Now, okay, how might we do that? Let's build some relationships and start there. And it was integral to setting up that work.
Okay, thank you both. Faisal.
Thank you. First of all of that is really, really exciting, and my comment is also meant to be very innocent and with no agenda. I think it would be really good to have an integrated research approach across the system, which includes providers, and I think I'd really welcome a sort of more connected conversation, partly because I'd really like to think that strategically we're more aligned, first of all. Secondly, I'm interested in that comment, which I completely take on face value, that you are self-funding and there's a little bit of resource that isn't self-funded. And I'd like to understand how that works across the system and how we can support each other better. So I'd really welcome a wider conversation with research leaders across the system, both in acute community mental health and outside of the hospital setting.
Thank you.
And just before I come to you, Clara, if I may, Leslie, was yours on a similar subject? You just pop your mic on.
Yes, it actually was, because I think that, you know, we all talk about, well, we're different and we have a different view. There are some things across the research and innovation agenda that we actually do share, and some of that is also around the stewardship of the funding that we do receive, which is that if there is infrastructure that we can share, it really does then give us greater effort, because, of course, our shift is much more around the prevention agenda, community agenda, and therefore we are probably moving much more away from this happens in this environment, this environment. There is a continuum across the research. But I do just want to call out, because I know Clara and Frankie, you were involved in helping us. The acute system, we've done something quite similar to say we do not want 3 lots of effort that are not joined up. We want to be able to think about what is the research that really drives us. And in the Norfolk system, of course, we have our our Norwich Research Park, where we've got an expertise that absolutely goes to the core of prevention. So I absolutely support the loaded question, the next loaded question, and really I think that this is an opportunity that we shouldn't miss. I think there's a lot to learn from each other.
Over to you, Clara.
Thank you. Yeah, I absolutely agree. We do have a group set up on the back of the Norfolk and Waveney strategy that does meet every 6 months to look at what we're doing. What I've also been hearing is that we don't need any more strategies. We've got one, actually let's expand that over to Suffolk now that our responsibilities are Norfolk and Suffolk wide. So we have got a little bit of more relationship building to do outside into Suffolk, I think, so working with all of our providers there. I would say that we do work really collaboratively, so where there are research projects that are delivered in primary care, they absolutely get support from our acutes in terms of we need some scans, we need some pharmacy support, whatever that might be, that does exist and it is happening. I think I was more describing a situation where the delivery of research projects is very different in a general practice than it is in a trust where you've got a clinical research facility, I suppose, that's there. But I think we have got massive assets that we can capitalise on, which we probably aren't doing to the best of our ability yet, but very happy to talk offline.
Great, thanks, Clara. Ed's going to make a suggestion for a way forward.
I know you're committed to coming regularly, 6 monthly, but I think if we could bring back a paper around integration and alignment of effort, because I do hear what you're saying, but I also know that the acute trusts in this ICB are all determined to make a left shift. And so the culture is shaping and changing quite quickly, and I think we've got an opportunity to integrate the research agenda to support all of us and align. It doesn't mean that we have to consolidate, but the collaboration now needs to be formalised another step, I think.
Yep, very happy to do that, thank you.
Happy to do that. Timing, Ed, on that, do you think?
Clara can advise, but at least 3 months, I would have thought.
Yeah, let's put it in the forward plan anyway, Tom. Thank you very much. Thank you, Clara. Colleagues, that was a really useful debate, and thank you very much for your contributions. I think, other than the action that we've just logged into the forward plan, we're asked to note, support, and endorse, and I think we endorse the direction of travel. Everybody agreed? And thank you for the great work. Thanks all. In which case, moving on to item 12, the Lampard inquiry update. Lisa.
Thank you. So this is one of the regular 6-monthly updates on the Lampard inquiry that Suffolk and North East Essex ICB previously had and will now be bringing to Norfolk and Suffolk ICB. So the paper details Norfolk and Suffolk ICB's continued role as a core participant to the inquiry and our continued commitment to participate and support the inquiry investigation relating to Essex Services and Essex Commissioning. The report has the updated timelines, the hearing plan, and details of the progress of a third Rule 9 request that we received as ICBs. And I think also just to note that the inquiry moved into its substantive investigative phase in March, which is where it will be considering systemic issues and concerns raised by bereaved families in the evidence gathered to date. I will continue to bring a 6-monthly update, if that's okay. Thank you.
Thank you, Lisa. Any questions for Lisa? Otherwise, David, yes?
Yeah, this is quite a long time scale this is going on over, and I suppose the obvious question is, what are we doing about key messages that come out from this process before an actual report comes out? So it's very interesting to read this, but actually I'm almost more interested in what are the learnings that we are gathering by being there and participating, and how do we as a board get assurance through the process rather than, as we see from the Grenfell inquiry 10 years later, finding out what happened 10 years ago. So I'm more interested really in understanding how we're picking up those learnings as we go through the process.
It might be helpful, maybe the next report I bring, I can make sure that I capture that. So we've always said one of the benefits of being a core participant to the inquiry is the ability to influence the recommendations, actually, that will come from the inquiry. Certainly, we've had lots of conversations with our KC and legal team around commissioning infrastructure changes and the challenges that's made to actually being able to describe over a 25-year period of time, actually, what has happened in commissioning for mental health across Essex. The learning is not, we are receiving some learning, but it's quite unsophisticated at the moment. And I think as now they've gone into their investigative phase, there is a chance for us to really kind of consolidate that. As a team, we meet very regularly, and we kind of talk that through, particularly around the safeguarding aspects of the inquiry. But I can definitely bring something back that is more focused on that.
Thank you, David. Thank you, Lisa. Any other comments, questions, otherwise received and noted? Good, thank you very much, Lisa. I think I'm sticking with you, Lisa, for the out-of-area mental health
Yeah,
inpatient.
Thank you.
All
so
yours.
This is this paper has two parts to it. So firstly, that it's an update on the out-of-area mental health inpatient census, and then there's an update on patients placed at St Andrew's Healthcare in Northampton. So the first part, we all know, as part of the medium-term planning framework, there is a direction to cease all out-of-area placements for acute psychiatric intensive care and locked rehab settings by March 2028. And as part of kind of understanding where systems were with this, we were asked to complete a census on the 1st of April. And that was the first piece of work that we had done across Norfolk and Suffolk, actually, to understand our patients that are in out-of-area placements. So you will see that we, on that day, it showed that we had 25 individuals from Norfolk and Suffolk who were placed out of area. And it's really easy to start looking at this as a target, but it's not a target. This is about people being placed far away from their social networks, their families, and all those things that I know everybody will know. And actually, in some instances, it may be appropriate because it may be highly specialist treatment that they're receiving, but in most circumstances, actually, it's not okay, and we need to do better to make sure that those numbers are lower. One of the interesting things through this process was, and we were asked to give assurance that as an ICB, we knew where all of our out-of-area people were. And on that day, we did know where all of our out-of-area people were, but it wasn't easy to do that because out-of-area placements are commissioned by different organisations, and there was no central database that said, oh, this is a list of our out-of-area our people that are being placed out of area. And that's important for two reasons. Firstly, we have a responsibility to know where our people are and to be assured that the commissioner visits or whoever has commissioned that placement, that they are assuring themselves that those people are safe and getting the right outcomes for their treatment plans. But secondly, if we don't know where people are placed, how can we do the work to reduce the placements? So actually, it was really informative. It showed us that we've got a lot of work to do. And one of the recommendations that we have for the board is that we would like to develop a single centralised source of information for all out-of-area placements. So that will be working with NSFT, with HPFT, and ourselves as commissioners. So we would really appreciate the board's support with that. We would also like to commence a panel oversight process for ICB commissioned out-of-area placement requests. So that will be part of our governance. It's a really important, we had one recently to consider a request, and it's a really important check and challenge around actually you're requesting this out-of-area placement. Let's have a conversation. I think, Mike, you joined it. Let's have a conversation around, is this the most appropriate place? Is this the most appropriate thing? Have we thought about, and the kind of collective discussion around that. So that was the other recommendation. Do you want me to go on St Andrews?
Should we do this one first and then
Okay,
St Andrews?
sure. Yeah.
Is that okay?
Yeah, of course, yeah.
And Lisa, on your second point there, second recommendation, these are on page 92 of the pack, colleagues. But on your, are you have you thought the membership through, Lisa? Do you envisage a non-executive member?
That would be great.
Would
that
it?
would be great, yeah. That would be great.
I'll have a chat with colleagues. Okay, that
Thank
might
you.
be some take up on that. I'll come to Faisal, if I may, and then to you, Ed. Is that okay? And Janet. Okay, start with Faisal. Thank you.
Thank you very much, and fully in support of that. And just to highlight and reiterate that not all out-of-area placements are inappropriate, as you say. And there's 2 or 3 levels, and I know that it's a system piece of work, and there's more than just our provider involved. But I think there's 2 or 3 levels to think about this at. First of all, each provider, I'm talking about my own provider for a second, we've got to be very mindful that we manage our acute and psychiatric intensive care placements internally well, and we worked really hard in NSFT to manage that a lot better over the last 6 to 12 months. But then we should also be drawing on our mutual expertise and assets across the system, because we have some specialisms that exist in one provider and not another, and we can certainly work better across the system. And then inevitably there'll be areas of expertise that don't exist within our system, and it's absolutely the correct and good practice to have a panel approach to that with oversight. So I'm completely in support of that, and really, really happy to think through it alongside other colleagues.
Well, thank you, Faisal. Ed?
Again, this isn't a loaded question, but in fact, this one probably is actually. But I'm just struck by the fact it took a bit of time to get a list together of all the people who are out of area, and it seems like such an obvious thing. What's been the barrier to doing that?
So the barrier was that the information was held by different people in different organisations, and it was the first time coming together as a new ICB that we had tried to do that across both Norfolk and Suffolk. And also some of the information even within organisations was held by other people. So we weren't just looking at what's the number of what is the number and where are they? We were also looking for assurance of when the last commissioner visit was and what the outcome of that was. And some of the information was held by kind of bed management teams, and some was held by clinical teams. So actually bringing it all together was quite tricky. Yeah.
Faisal, did you want to comment on that?
Yeah, and I was just going to say that, and I can understand that challenge, and looking at the nature of the specialisms that are highlighted in your report, I suspect that the bulk of them sit in one specific area of commissioning. Having said that, of course what we need, as well as panel oversight when you ask for specialist placements, is a system of regular review and monitoring of those placements. That's actually, I think, more important than the entry.
No, good point. Lots of nods to that, Faisal. Thank you. Elaine?
So this just looks like a really sensible suggestion. So my only question was really, is there any disadvantage of doing it or any disbenefit? For example, security of sensitive information or something. So is there any disbenefit at all of doing it?
Not that I can think of.
Okay. Thank you.
I obviously can't think of any. I don't know if Faisal.
Thank you.
Okay, thank you. Janet?
Thank you very much, Chair. And Lisa, I would absolutely support this. Having been a non-executive mental health provider for many years, this was probably an area of great frustration that we were never quite clear who we had, where they were, who was paying for it, all of those things. The panel that you're suggesting, is that an approving panel or is that a review panel? Because if it's an approving panel, it'll have to be quite flight of foot and managing the risks.
Yeah, good.
So it was an approval panel, but actually we've had one so far to consider one particular patient that was referred to us for a specialist placement, and we didn't really operate it as an approval panel. I think this is part of the conversation we need to have with clinicians, because at the end of the day, if Faisal refers somebody for an out-of-area specialist placement and, you know, has that knowledge and expertise, we can check and challenge, but I'm not in the context of NSFT that I would say, no, you cannot have that, because I'm not aware of the risks and I don't hold the accountability for that. So I think we probably just need to work that through, Janet. Yeah.
Work in progress. Okay, thank you. Ewan.
Yeah, thanks. My question's sort of closely linked to that. I think, you know, we'd all agree that minimising inappropriate out-of-area placements is really important. I have a close family member who has been in another county, an out-of-area placement, but that family member also spent very prolonged periods of time in an emergency department and on acute hospital wards. So I think it's absolutely critical that any process that is implemented does not increase the length of time that patients in severe mental distress spend in inappropriate acute sites. You know, partly from the provider perspective, but, you know, certainly my personal experience of the patient experience in that setting, it means that this is really vitally important, that we don't solve one problem and make another one worse.
Yeah, good point, Ewan. Well made. Thank you. David?
Yeah, really an observation. They've just spent a lot of time talking about the relational experience, and now we've got a paper entitled Out of Area, which is the way that we and the NHS think about things. So I'm welcoming this balance about a committee that considers individual patients and what their requirement is. And I suppose my other question is, what is area now? Is it an ICB area? Because if it is, frankly, we're going to get bigger and bigger, and we're going to end up having people that are still 3 or 4 hours away from home because we've now got a bigger ICB. So I think we have to be very careful of using this word area and out of area, and I think we've got to refocus our minds back to the discussion we've had earlier in this board, which is around people and what's best for that individual and their family.
I think Faisal knows the answer to this question, David. Go on, Faisal.
I'm trying not to open a can of worms that Lisa's not going to thank me. You're absolutely right, and it depends on the need, the specialism, what the provider provides, what the system provides, and certain things are just not provided at a system level, and you need to go out. For me, it's all about what's inappropriate for that person at that time, and if there are inappropriate out-of-area placements, that's where our focus should be. The flip side is equally awful, where we're actually creating barriers to people who need a specialist placement somewhere in the country because that is their absolute urgent need. And so I think there's a balancing act, and I think the panel and the review mechanism is what we need.
Excellent, thank you. People-centred, people-focused. Right, good. Colleagues, on page 92 there are 2 recommendations which I'm not going to read out. You're well able to read them. We've just discussed them at length. Are you content to approve both recommendations? Agreed. Lovely. Thank you very much, everybody, and look forward to hearing more about this one. Item 14, performance report. Richard.
Thanks, Will.
Sorry, what have I done?
St Andrews.
Oh, sorry, you're so correct. Thank you. I was going too fast. I was just conscious of the clock, Lisa.
That's okay.
St Andrews.
Yeah, very briefly, I was asked to give an update on the position of our people at St Andrews Healthcare after the inquiry into the organisation. So our current position is that we have 3 Norfolk and Suffolk people remaining there, 2 Suffolk people, 1 Norfolk person, but we have really robust discharge plans in place for each person, and we are expecting them to move within the next few weeks. Thank you.
Thank you, Lisa, and sorry for forgetting that you had to do that still. Any questions for Lisa? Noted. Lovely. In which case, thank you. On to item 14 now, Richard, all yours.
Thanks, Will. So we thought it might be helpful for the board, given it's our first meeting, just to pause on what's the proposed approach to performance management, which sounds a bit odd, but actually the role of the ICB is evolving in terms of its relationship with providers and also within NHS England. So you'll see on slide 95, we took this through our Finance, Performance and Workforce Committee, and Janet might comment when I finished, just to kind of get a sense of, does this seem about right? So briefly, effectively, NHS England have now got the accountability to work directly with our acute NHS providers around the performance of the organisation. There's a but we've still got contractual responsibility in relation to the contracts that we hold with each provider, whether they're NHS acute or indeed any contract that we hold. So it's a little bit grey, it's fair to say, and we're working through between our provider partners, NHS England, and ourselves, what that looks like, so that we don't kind of create repetition or confusion around our roles and responsibilities. So as part of that, what we're suggesting locally, and there's an alignment broadly with our neighbouring 2 ICBs, we met a couple of weeks ago, is that we will have in place effectively a contractual performance meeting with each of our NHS providers on a monthly basis, one meeting between a multidisciplinary team internally from the ICB and that provider to effectively talk about any issues related to the contract, anything that needs a discussion effectively. And we've also put in place a more informal, every 6 to 8 weeks, exec to exec with each major provider. So that's an opportunity really to either get escalated actions where needed, but to be honest, the vast majority of things just should be sorted, they are being, but also to have more of a conversation, strategic conversation, very much like we've been having today, with each provider collectively across our different roles within the 2 organisations. And then turning internally, given we spend upwards of £4.5 to £5 billion of public money, we need to find an organising methodology between our different parts of what we commission. So what we're proposing to do is have a series of MDTs for each part of the areas that we commission under the lead of one person, and they will draw together, as it says on the tin, a multidisciplinary team of the different teams, whether it's finance, contracts, finance, commissioning, and they will effectively hold the accountability for that basket of contracts and that commissioning area. And that will sit under then the Finance and Performance Committee, and we met for the first time last week, which was really helpful. So to complement that, again, we're trying to streamline the amount of material and the amount of performance material that we produce. And obviously we're trying to standardise the approach we've inherited from our 2 legacy ICBs. So you'll see within the pack that we've got a fairly standardised now performance report at a helicopter level that looks at our key constitutional standards and key performance indicators, predominantly the national ones. There's a but what we're also looking to do is then develop on a quarterly basis that's something that aligns to what's called the NOF KPIs. So each organisation, including ICBs, and it's on the next slide, will have a series of KPIs that we're held accountable for as an organisation, and that will help influence the overall rating that we're given on a quarterly and then an annual basis. So we'll be also monitoring that set of KPIs, which are far more outcome focused if you have a look, and they're far more longer term, many, in terms of their ambition, whether it's cancer early diagnosis, hypertension, etc. So what we're envisaging the board will get is absolutely on a monthly basis a short report that Janet and I will outline, given the majority of that work is happening through the committee structure, and then we'll also bring on a quarterly basis more of an understanding of how we're doing on those ICB key performance indicators, and also how we're doing on our 5-year plan. So I'm keen that we don't leave it till the end of the year to know that we may be off track on some of the key commissioning deliverables that we've set out. So we're just trying to get the balance right, so that will take a little bit of time between what goes to committee and what comes here, and we'll also use some of our board development time, I think, also to talk through this in a bit more depth. Just because you might be interested, the NHS Oversights Framework we're expecting to be published later today. It was meant to be at 3, so in 8 minutes' time, but we'll see. So on this slide, on page 96, these were the draft indicators that related to ICBs, and our intelligence team has effectively tried to track, looking at the legacy 2 ICBs, where would we be in terms of either quarter 1, 2, 3 or 4 against each of those. And you'll see overall it's a relatively strong position. There's certainly more greens than reds, but it also points to a number of areas where we definitely need to be doing more work as an ICB to ensure that we're doing better against that outcome. So the 2 that stands out is annual change in the size of the waiting list, where we're in the bottom quartile across both legacy ICBs, and also the percentage of patients with hypertension recorded who have their cholesterol levels managed to NICE guidance in Norfolk, and that is definitely a priority area that Frankie and I have been looking at. So hopefully that will give you a sense of these are the areas that the ICB is going to be effectively accountable for directly, and that will also sit alongside a qualitative judgment that NHS England will reach on our leadership ability. So they'll be speaking to providers around the table, be nice, on a quarterly basis or slightly more, and then also there'll be an override factor. So if as an ICB we aren't in financial balance, then that also means that we will not be in what's called segment 1 or 2, 1 being best. It would automatically go to a 3. So financial is incredibly important, stating the obvious, looking at these KPIs and making sure that we have work underway within these areas. And then obviously the way that we operate, so particularly going back to the letter that we sent to Sir Jim, the way we operate as a system is incredibly important about how we ensure that we're improving outcomes for the population. And then the rest of this first report, which I'm not going to dive into, Chair, gives you an overview of where we were. There's always a 2-month lag in data, so this gives you the position February, March time. Obviously things have evolved significantly with all of our providers since then, but at this point I won't go through the detail, I'll open it out if people have got questions.
Thank you, Richard. Janet, do you want to comment from a Finance and Performance Committee point of view?
Yes, if I may, we had a really good development session, I would call it, last week, working through this. And we're very keen to have the majority of this work happening in the Finance Performance and Workforce Committee rather than the detail coming to board. So we'll design it in terms of good governance, deep dives into the things that are important, but also then take this whole alert, advise and assure principles into how we report back to the board. So you'll get a summary report from me, and we're hoping 2, 3, 4 pages of high level information. It's learning for all of us, changing from being holding the trusts and the system accountable to doing the contract management. So we'll learn through that. And I think we talked about an evolution rather than a revolution in this. And if there's anything at any point where the board members think they're not getting the information they need, please just let us know.
To you. Lovely, thank you. Frankie?
Thank you. And Janet and Richard, two things I wanted to pull out, particularly on the ICB oversight framework. Firstly, we're all competitive. And that is a good thing, because we should be striving for the absolute best for our population. And secondly, over half of the metrics in here are absolutely in support of our earlier discussion about moving care into neighbourhoods, moving care to be proactive and preventative rather than reactive. So we've got cancer screening, we've got health checks for people living with SMI and learning disabilities, we've got vaccines, we've got care processes for diabetes, improving cardiovascular disease management, smoking cessation and early cancer diagnosis are all in there. That is what we should be doing, that is what we are doing, and so I'm really pleased that we're going to be judged on our performance on those.
Great, thank you, Frankie. Kirsten?
Thank you very much. This all sounds eminently sensible from an ICB perspective, but I'm going to ask the layperson question here. That basically means I don't know enough about this, so that's why I don't know the answer. But from a provider perspective, what you said at the very beginning, Richard, about, sort of there's going to be a duplication or 2 different types of review or monitoring going on. How does this feel for providers? Is this a level of bureaucracy they didn't have before? And is there, are there people in the room who'd like to answer that question?
Before you answer, Richard, I think Faisal, were you going to comment on that?
I was. I suppose we've got to see how it goes. That's the first thing. The risk is that we get a duplication of the sort of NHS England assurance asks in the contractual style meetings. So we've got to be careful of that. And the real risk is that we start getting contradictory messages in the same quarter. And so I think we've just got to see how it goes. And the proof will be in what is the focus. What we don't want is the ICB meetings are essentially a subset of what we already have in terms of NHS England assurance, but we can work together to make that not be our experience.
Not to happen. Adrian?
I suppose my comment is this is nothing new. In a way, we're going back to what used to be the situation a few years ago. I think it's been good working with, an ICB environment for a number of years, but this is the change in policy and we have to adapt to it. My second point is, and it links to Frankie's point really, that we are competitive. And we've all gone through a sort of, Howard's looking at me as if, yes, definitely he's competitive. And we've all gone through an annual business planning process with setting activity plans and so on and so forth. I think NOF will supersede a lot of these plans that have been set, particularly when we talk about referral to treatment plans and where the East of England has to get to, and where we need to get to as an organisation and where we need to get to as an ICB, that NOF and that sort of pressure of ranking will drive performance improvement, and that's got to be a good thing. So I think the plans in some ways become the bare minimum, and is where you go on top of that to improve your NOF rating and the competitive urge that we all have to improve services. Positive, I think, positive.
Okay, thank you. Let me see in my list. Ed, I think you are next.
Yeah, thank you, Richard. On the oversight framework metrics, so one, they're great metrics, I think, pleased about that, and two, we're largely green, so that's a good starting position. However, as you've pointed out, the one metric where we are red in both Norfolk and Suffolk is change the waiting list. So I really think we need to bring a proposal here around outpatient transformation that is going to push the boundaries a bit. I know I've got some thoughts in my inbox from colleagues in primary care about this, but I think this is a big one to go at. And let's be honest, from a national perspective, waiting lists is and thinking about resources, contingencies, is there non-recurrent things we can do to get some real progress on this? So I'm kind of saying, great to see the strong position, but let's not be complacent and let's really go at the red metrics really hard.
So I know you're aware, Ed, but just for everyone else's benefit, absolutely, this is one of the areas that we said was one of our 8 priorities for this financial year, or the next 2 years, was effectively re-looking at the whole planned care model within Norfolk and Suffolk. So we've commissioned some external support that's working. I've met them yesterday, actually, is working with us. There's 2 parts to it. Firstly is to stress test our existing plans as a system partners around how confident are we within our existing plans, going back to Adrian's point that we've submitted, that will get us to where we need to in 3 years' time on RTT. The second bit, which I think is the more exciting bit, is a fundamental relook at the outpatient model as a major contribution to that, and take up Sir Jim's challenge that he's made several times in the last few weeks around we need to think differently around what that outpatient model looks like. And that's the challenge that we've set ourselves to work with partners around what could that look like if you kind of started afresh. So we're expecting that work to be happening it's happening now over the next 2 months. And I'm writing to partners imminently to talk about could we get some kind of workshop time specifically on that if there's an appetite to think about what that could look like.
Thank you, Richard. Just let me do a little bit of management. Adrian, did you raised your hand? Are you done as well? Okay, and Leslie, is yours on this specific point? Go for it then.
So I think all systems, no matter where they are, have been trying to grapple with how do we manage an outpatient system that many people would recognise from decades ago, and it really hasn't fundamentally changed. The only thing I'd say is, and it's great that we're doing work, I think this is for me a bit of a moment where we are already in this space having to go really quickly trying to pick up the national model, so there's national models. And I just wonder about our cadence and urgency of timing. So we're going, then we're going to get something else coming around the corner. And I think it's just a reminder that potentially what we should have done a bit earlier was to say, if this is important to the ICB, then it's important to us. How do we go together? The other thing that I think, and I've said this before, but the ICB has an absolute role in making sure that the way that you commission us drives for the intention. And therefore, it's not about incentives, it is actually driving us, that there is no ability to continue to do what we've always done, but in fact, we are agreeing that this is the model and therefore fund us to reach that model. Because at the moment, there is lots of voices. There is a whole national group looking at outpatients. It's part of our recovery, as you know, within our University Hospital Group, we have put in a 2-year recovery plan, of which outpatients is a major platform. Basically, and I listened to Jim Mackey as well, we know that currently what we're doing is servicing about 60% of people who no longer are receiving any benefit from us. And I think that the way that we connect with primary care is really the answer. But I also understand our systems really quite well, and we have to have some forcing functions, some levers, and often it is the money that will actually make change. It goes back to an earlier conversation around winning hearts and minds, and where do leaders actually start to say, the evidence is there, this is what we need. Now we are going to be directive. There is not a opt-in, opt-out. This is where you're going.
Yeah, thank you. That was very helpful. Do you want to comment on that, Ed?
No, it's just exceptionally helpful. Yeah. It's a clear mandate, isn't it?
Yeah.
We've got.
Yeah, no, thank you. Thank you for that, Leslie. Right, I've got Howard and then Antonia, and then I'm conscious we need to get moving, otherwise we'll be, well, I'll be in trouble anyway. Go on, Howard.
I guess it's a similar message to what everyone else has been saying to a certain extent. I think we're at the start of Back to the Future in some ways, just on Adrian's comment, and we just need, as a board, to make sure that we are mature enough that we check in at the right times to say we're not reverting back to the bad old days of, strict contractual levers, etc., because this is clearly a very ambitious board that wants to work well together, etc. But I also agree with Leslie, there's that tension between, we have to get the balance right as an ICB between wanting to be collegiate and working together and also using those levers as effectively as we possibly can. And I think there's going to be a lot of learning for us as a board, I think, over the course of this year, personally.
Yeah, inevitably. Together. Antonia.
Sorry, I laughed when you said about cholesterol. I've spent pretty much every day of my, when I go to my general practice, arguing with patients about their cholesterol and how to treat it. And what we are fighting against is the national press. Comments, my friend said, my relative said, my neighbor said that statins are devil and you shouldn't take them ever. I don't know, I'll have this conversation daily. One of the things that I think we as the ICB board need to do is we need to have a campaign, communication with our patients, I think just to pass our message, and then they will come our way.
Any further thoughts, comments? No? Colleagues, this has been a really useful debate, I think, and probably is not going to be the last time, won't be the first, won't be the last time we have this debate. We're actually asked to note, but I think, Richard, you were asking for support for the process. In the context of the debate we've had, are we happy to support process and look forward to further reports? Okay, thank you. Now, we are, as far as I can make out, we keep catching up and then falling behind again, but we're about 12 minutes behind, and we only have a 10-minute break slotted between this public board and the private board, the Part 2 board, which will follow. So you're in danger of using up your coffee break at the moment. With that in mind, Howard, can I go to you, please, for the annual budget 26-27?
Yes, thank you. And so before turning to 26-27, just wanted to confirm the outturn positions for 25-26 for Norfolk and Waveney and SNE, as these were not concluded at the last public board in March.
Yep.
I won't confuse everybody with all the deficit support funding that came down and confuse individual organisational pictures, and it doesn't always help with clarity and financial positions, but suffice to say that both systems ultimately delivered what they said they would in 2025-26, which is obviously a strong outturn position for both legacy systems, and I think reflects well on the discipline shown by all partners through what was a challenging year. Also suffice to say that those numbers are subject to external audit, which is currently ongoing. Turning to 2026-27, as the board will recall, a balanced Norfolk and Suffolk ICB financial plan for the year has been approved. That was done in February 26 this year. The budgets presented in today's paper for board approval are consistent with that approved plan and set the financial framework against which the new ICB will operate in its first full year. The plan meets our statutory financial duty to deliver break-even. It's compliant with the mental health investment standard growth target. It remains within the running cost limit for the year, and subject to any further limit changes, it maintains the ring fence on primary dental services as well. I just need to draw the board's attention to the scale of the efficiency challenge embedded in the plan. Delivery requires a cost improvement plan of £101 million for the ICB. The principal programs are best value medicines, the corporate work stream and complex care, as well as the contract and service reviews, including those that sit within strategic commissioning. We're currently in the process of finalising planning for 7 million of the total 101 million and expect that work to be concluded in June. I'll report to that at the next board. The total ICB plan is 4.95 billion of resource, of which 4.87 billion relates to programme expenditure. That's spend on services. 46.7 million to programme running costs and 27.3 million to administration running costs. The paper sets out the budgets at director portfolio level together with the efficiency programme by responsible director. There's a bit more work to do on just finalising the distribution of admin running costs, but we'll deal with that outside of board if that's acceptable, Chair. Mm-hmm. So there's been a series of meetings between my team and the responsible directors, and the budgets have also been reviewed by the Finance, Workforce and Performance Committee on the 14th of May, which has recommended them to board for approval. So we're seeking today for the board to approve the 2026-27 budgets by director as set out in the paper, and just to note the delivery risks and also that the final distribution of the programme and admin costs will be approved by myself and the Chief Executive. Happy to take any questions.
Howard, thank you very much. Any questions for Howard? Janet?
Just to add to Howard's comments, we did scrutinise this at Finance, Performance and Workforce in great depth. And, you know, this will be another strand of the work that we do, and we'll be scrutinising the delivery of the CIPs and also holding to account for delivery of budgets, and we will escalate as appropriate.
Okay, thank you very much. Any other points or questions? Otherwise, on page 119 of the pack, you've got a single request to approve the 26-27 budgets by director, which have been derived from the financial plan, which we approved in February 26. Is everybody content so to approve? Agreed? Lovely. Thank you very much. Was there anything else, Howard?
Nope.
All done? Thank you. In which case, item 16, the committee highlight reports. First of all, a general question. So you've seen the new format now about alert, advise, assure. Are you happy with that? Any negative thoughts about it? Does it work for you? Happy with it? Yeah? Okay. Any comments I'm sure we'd be pleased to have on reflection, if you have any, please do make them. There are 4 highlight reports before you. Each chair, please do say if there's anything that you want specifically to raise for the attention of the board as we go through them, otherwise they're there to note. Audit, David, anything specific? Or Frankie, sorry, yeah.
Sorry, I just wanted to draw the attention to the board about the discussion we had on intensive and assertive outreach, because that has come to the board previously, so just to note that that is ongoing and that we've supported that case.
Indeed, and that went to the Strategic Commissioning Committee, didn't it? Yes, so Fanwell will pick that up, I'm sure. David, anything you want to say about audit now? And do raise your hand if you have any questions specifically. Strategic commissioning, Fanuel, I guess Frankie's probably covered one of your points.
Yes, I was going to mention that. Thank you, Frankie. As you all know, this is something that we've been discussing, over quite a long time, and we're quite pleased that we're able to put some investment into that. But also, specifically to mention the fact that for the 2.5 million recurrent investment, there is quite a substantial amount that is reserved for the voluntary and community sector, the 870,000, which is again something that we've been, talking about in terms of how NSFT works alongside our voluntary and community sector. And there is, a bit of further development work that we recommended in terms of the return on investment and evaluation framework that we need to work. We also approved the Suffolk end-of-life business case, again with sort of similar recommendations. But just quickly on that one as well, we also talked about how we look at Norfolk and the investment sort of to align the work that is happening in Suffolk. So there is some work that is going to be done alongside that. I think the other parts of the meeting we've already discussed, the letter from Sir Jim Markey, and also Richard talked about the planned care demand management work program as well, working with PA.
Okay, thank you, Fanuel. And again, if any questions, do raise your hand. Janet, anything on REMCOM you wanted to flag in addition?
Nothing specific. I just wanted to advise the board that we continue to meet monthly until the restructure is complete, the redundancy is complete, and also the policies are aligned.
Yeah, indeed. Okay. David?
It's just about staff survey. Does that come to board at some stage? I sort of know it goes through committee, but it's one in the past that I think has been important enough to bring to board.
Indeed it will, David. We took it to our last REMCO a couple of weeks ago, so the intention will be to bring it back here. But the underlying message is that will feed into our ongoing development work around our organisational development.
Okay, thank you. And Elaine, Quality and Committee?
Yeah, I think just to call out a thank you to Health Watch, now known as Knowing Works, who brought along a lived experience case study, which was about a young woman who'd experienced, a young mother actually, who'd experienced mental and physical challenges, and it really helped inform the discussion. So, I mean, we'll be continuing to have more case studies come to future meetings, but just a call out of a thank you for that, which was really helpful.
Okay, thank you, Elaine. And again, no questions. Janet, did you want to say any more about finance, performance and workforce?
So I just wanted to apologise to the board for there not being a report. We met late last week, so the timing was off, but we're hoping to align the timing in future. In terms of the points I wanted to make, they've been made through the performance and the finance conversation, so thank you, Will.
Okay, thanks, Janet. Thank you. Any questions specifically, colleagues? Otherwise received and noted. Lovely. In which case, item 17, amendments to the Constitution and the Governance Handbook. Amanda.
Thank you very much, Chair. So I take the paper as read, but board colleagues will be aware that last board meeting in April we actually approved our Constitution. Since then, we have given further reflection to the current membership of our non-executive members, and we have agreed that we should perhaps increase the capacity from 4 to 5. So part of this paper is seeking board approval to actually apply to NHS England to amend our constitution to reflect 5 as we move forward. And then the second item that we need board approval on is to approve the terms of reference that were not available in April, Chair, and they were for our Norfolk and Suffolk Neighbourhood Committee and Primary Care Committee. Now that we have actually considered, we're bringing both of those terms of reference for board approval today. And finally, we have reviewed the finance, performance and workforce terms of reference, and we would like to bring that for approval again today. Thank you, Chair.
Okay, thank you, Amanda. Just a quick question from me. Do review dates need to be put in on those Norfolk and Suffolk committees yet? What will the next review date be, assuming we approve it today?
I'm looking to my colleagues, but I think a 12-month review may not be a bad idea.
12 months? So if that's added, everybody content? Any other issues or points, comments to raise? Otherwise, we're asked to approve, so approving with a 12-month review date to the Norfolk and Suffolk committees. All agreed? Lovely, thank you very much. And I'm sticking with you, Amanda, for risk management and the BAF, please.
Thank you very much, Chair. So this is kind of similar to Richard's opening regarding the performance report. So now that we are one ICB, this was discussed at the recent audit committee a couple of weeks ago, and we felt it was now timely and appropriate to take stock of actually how we as a board manage risk and our approach to board assurance framework as we go forward. And we actually concluded that we need to be aligning much more closely to our overarching strategy. And with that said, the audit committee agreed that we needed to really take some time out and work through collectively what it is we're actually wanting our BAF to achieve. And having said that, we've got one workshop with the audit committee coming up, and we're planning to hopefully bring a similar workshop to our board through one of our development sessions going forward, so that we can collectively buy into the approach that we want to adopt and adapt for BAF, and actually what our appetite is on risk as we move forward. So that's kind of what we want going forward, but that doesn't mean that we're not actually managing our risk as we speak. We continue to manage risk, and those risks are continually being managed through our resilience and risk group, and any risks of significance will be reported through the appropriate board committee, which will then be escalated as need be to our board as an interim. So there is a lot of work going on behind the scenes, but we think collectively this will be better as we move forward on how we truly manage all things risk and BAF as we move forward. And hopefully David, Audit Chair, will agree with that.
Anything you want to add, David?
No, other than it is a very difficult area to get our minds around as a board. I've not sat on many boards where the board has really been engaged to the extent that I think it needs to be. So I do think we do need to allocate particular time in a development session to get our minds around it and to set our and to set our limits as a board, which then committees can work to in terms of their reporting up and escalation of issues.
Yeah, good point. Leslie?
I totally agree with what you've said, David. But what's interesting is that as a newly formed group, we're going through exactly the same thing right now. And I was just going to make a suggestion that as the ICB works through their risk appetite, it may be useful to reach out to partners, because there will be some things that we look at as part of our strategic risks that in fact we should have an aligned appetite, rather than potentially coming up with those points that inevitably could cause some tension, where we've determined to look at things quite differently, understanding the lens by which we take. But there are often things around some of those forward-looking strategic risks that we should make sure that there is alignment across our system.
Definitely. I think I saw a lot of nods around the table there. Yeah. Thank you for that, Leslie. Any other questions or points? Otherwise, Amanda, I think we're asked to specifically approve the interim arrangements, approve the development of the new BAF in the way discussed, and we're handing this over and we're delegating this to audit committee to manage the process and report back to board, but with the appropriate relationships with partners as described. Everybody content? Agreed? Thank you very much. In which case, that takes us on to item 19, which is questions from the public. Now, as I said at the beginning, what we're going to do is ask the relevant exec directors to give a short summary of the question and the answer, but then the full question and the answer will go on the website. So first of all, Mark, I think I'm coming to you for, I hope I'm pronouncing this correctly, Colleen Guacameli. Question number 1, over to you.
Thank you, and I will be brief and trying to summarise. But the question was whether the ICB could report on whether the vocational rehab service is being considered for the 2 neighbourhood hubs to support people in returning to work after a period of ill health, to stay well and work while managing a long-term condition, and also gives a little more detail beyond that as well. So the answer is that neighbourhood health centres are a central theme in the government's 10-year plan, and something we're considering very carefully. It's very live for us at the moment, and we're linking in with region on this. So it's clear that more integrated neighbourhood-based approaches to care, shaped by local need and delivered locally across partners, recognising the importance of supporting people to remain well in work and return to work following a period of absence. So we will consider this as part of our plans. We haven't made any final decisions at this stage, but we will update accordingly.
Thank you, Mark. Question number 2 from Mr. Dooley. Over to you, Ed.
Thank you. I hope you're well, Anthony, if you're watching. So Anthony's question is around, could we publish written answers to public questions on our website, which I think we can do.
Yep. Okay, thank you. Question number 3 also from Mr. Dooley. Richard.
Apologies, this one's slightly longer, so thanks, Anthony. The nub of the question is, will the new board expect providers commissioned to provide services to do so in-house, and that any existing outsourced services will be expected to be brought in-house when the contracts are up for renewal? So from our perspective, our role as the ICB is not to mandate a single delivery model, such as requiring all services to be provided in-house, but to be clear on the standards we expect to be held accountable when we commission our main providers. Providers themselves are responsible for how they organise their services, including whether they effectively delegate or subcontract some of those elements to other organisations. But what's absolutely clear is that accountability overall rests with the main provider that we commission. So outsourcing doesn't remove that responsibility for quality, safety, or how services are delivered. Looking ahead, when services are reviewed or contracts renewed, we'll continue to consider the most appropriate delivery model in terms of how we commission on a case-by-case basis, based on quality, resilience and value for money for the population. And we'll also need to ensure that we're in line with the Procurement Act 2023 and the provider selection regime.
Thank you, Richard. Question number 4 also from Mr. Dooley. Faisal.
Thank you. Thanks, Anthony. And the nub of the question is around value for money and NSFT's use of County Hall as a base for some of our operations. Just a couple of things. In terms of some context, first of all, the initial move to County Hall in 2024 was in an effort to reduce our corporate costs and to focus more resources on meeting the needs of our patients. But actually, since then, we've made further efforts to sort of improve our value and get more efficiency. So we took a decision to reduce costs and only occupy 1 floor in County Hall from September 2025, and that's the current status.
Thank you, Faisal. Question number 5, also from Mr. Dooley. Richard.
Thank you. So this question, thanks Anthony, relates to corridor care. So the question's around, do we have the overview of how much corridor care is happening across the services that we commission, and does that provide evidence of a shortage of bed in each hospital, and thus the need to restore some beds that may not have been available? And also, Mr. Dooley's asked what the definition of corridor care is. So I think as a board, we'd all agree that corridor care is something we absolutely don't want to happen. And we're committed as a board, I think, to reducing, indeed eliminating that through the work that we do together. We do have a system control centre within the ICB that effectively is our operational hub that works with our partners on a day-to-day basis around having that oversight of the resilience of the system. So through that, we absolutely know, basically on almost a live basis with our partners, many around the table here, what's happening in terms of the number of beds we've got open, closed, corridor care numbers as well. The definition of corridor care is set nationally by NHS England, so effectively that can be that's on the NHS England website. Anthony, I'm happy that we share the link for that, but it defines corridor care as care delivered in non-designated clinical spaces where patients are managed for more than 45 minutes in a 24-hour period. There is a commitment from NHS England to publish corridor core data from May 20, so effectively later this month. So there will be that availability of data for all of the public to see. And as I say, we also get that through the work that we do through our own system control centre.
Thank you, Richard. And I'm going to stick with you for the next question, final one from Mr. Dooley.
Great, yep. So this one relates to digital. So how are we ensuring every patient's negative experience of engaging with or being affected by digital tech at primary and secondary level is recorded so that you can address negative experiences? Anthony expresses 2 experiences he's had recently, which haven't been as positive as he'd hope or we would hope. So we all the feedback we get from patients and the public about services that we commission is recorded through our standard processes, and we respond to that on an individual basis. But we also collect themes, where there's themes coming out, not just in digital, but generally in terms of our complaints and feedback that we get. And where those comments are most appropriate for a provider, we will share that and work with the provider in terms of their own work that they're doing, particularly in the digital space.
Okay, thank you very much. Question 7 from Andrew Livingston. Frankie.
Thank you. So Mr. Livingston has asked, bearing in mind our recent correspondence with Sir Jim Mackey, that in the short term our priority is to deliver the best possible care for our population, how it is that we have differing means of access to Tier 3 specialist weight management services for people who live in Norfolk and Waveney versus people who live in Suffolk. There's quite a lot more detail, but that's the nub of it. So we do acknowledge that currently there are some differences around how patients can access weight management support based on where they live. But we are working with our different providers to ensure that pathways are high quality and to ensure they do align across the 2 counties as quickly and as smoothly as we can, where contractually possible. And we are indeed committed to this, but we will provide a much more detailed response on the website.
Lovely, thank you. And question 8 from Louise Sargent, also for you, Frankie.
So Louise Sargent has asked how the ICB is meeting the requirements set out in a specific NICE quality standard on rare diseases. So there's 2 parts to this question. The first is the need for coordinated, person-centred care, clear points of contact, and effective navigation support to avoid people being repeatedly redirected, as we heard in the Catherine story earlier on, in fact. So we are fully committed to implementing this quality standard. We commission care structures designed to wrap around the individual, and today we have talked quite a lot about how we'd like to do more in that area. As strategic commissioners, we work closely with the specialist commissioning teams to ensure that patients have access to patient-centred support from those specialist centres, though they are generally situated outside Norfolk and Suffolk at the moment, for example in London and Cambridge. And we are committed to improve timely access to investigations and treatment for those rare diseases.
Okay, thank you. Question 9, still for you, Frankie, again from Louise Sargent.
So this is again picking up on the same quality standard, but asking what steps we are taking to ensure that our own staff understand the services we commission and provide the correct information to the public, and in particular also how to make a complaint about the ICB, as this person's obviously had some difficulties accessing the support they need. So we try to do this largely through our website. Our website provides information and links which describe the services we commission. We also have a directory of service that's been shared with our system providers. It is regularly updated, but it does change quite regularly, so I am very sorry if people haven't always been up to the minute. We do have a clear complaints procedure, and complaints are important to us. We listen and learn from them, and the details of that is on our website. But if that doesn't work for you, anyone needing to speak to someone, please do call our PALS service to raise a complaint. And the number for that is 0800 389 6819.
Thank you. And then finally, question 10 from Louise Sargent again, but for you, Richard.
Thanks, Will. So this question relates to a service that we commissioned, so the APMS service at 70 to 74 St Helens Street, which for the board's benefit is the health outreach service that supports marginalised and vulnerable adults in mainstream health services across Suffolk. Are they operated with a full suite of required governance documents, and whether the documents that patients are entitled to see are routinely made available? So in response to that, a full-length NHS standard contract was awarded to the Essex Partnership University NHS Foundation Trust, or EPUT, to provide the service adhering to the provider selection regime rules that effectively oversee how we do and carry out procurements. This contract includes nationally agreed conditions that all providers have to follow, including clinical governance and patient safety standards. We hold regular contract meetings with EPUT to provide assurance of the quality and safety of the services being delivered. But I think if Louise has got particular concerns related to that service, please do contact EPOT or ourselves, and we're happy to look into it in more depth.
Thank you, Richard. Thank you all. Any other questions from members of the public? Nothing additional? In which case, then, we are on to any other business now, non-notified prior, but I'm just looking around the table, so wave at me if you have anything. Otherwise, no other business raised. Thank you very much. Colleagues, 15:33, well done. Meeting closed. Next meeting, 15th of July in Thurston. Thank you very much, everybody.